Intro slide. And everyone, hi, I'm Jeanne Herb. I'm with the Rutgers University Bloustein School, and I've had the great opportunity to be the principal investigator on the project that we're going to be highlighting today. Before we get started, I'd like to turn it over to my program officer, Sallie George from the Robert Wood Johnson Foundation, to welcome you all. Sallie?
You're muted.
Sallie, you're on mute.
How many times do we do this, right?
I know.
All day, every day, and I still get it wrong. Good morning. Thanks, Jeanne. Thank you all so much for being here today. It's a really exciting day for the future of public health in New Jersey, and I'm thrilled to see so many familiar faces, as well as a lot of new ones. My name is Sallie George, and I'm a program officer at the Robert Wood Johnson Foundation. I'm a born and raised Jersey girl who's raising a family here, so the public health in our state is very important to me personally. I'm here representing a team of folks at the Robert Wood Johnson Foundation who care a lot about health in our home state. And I'd love to tell you a little bit about our strategy. We believe that New Jersey should be a place where everyone can live the healthiest life possible, regardless of who they are, where they come from, or how much money they make. Unfortunately, generations of structural racism have led to policies and practices that cause populations living in proximity to experience very different realities, with far too many residents suffering from a lack of opportunity and poor health outcomes. By working with others to confront these unfair and unjust conditions, RWJF seeks to secure the promise of a healthier, more equitable New Jersey. Our grant-making strategy is designed to spark the long-term change needed to eliminate barriers to health equity for everyone in our state. Our work focuses on the following areas because they offer the best chance to improve the lives of millions of New Jerseyans, especially those who have suffered the effects of structural racism for generations. We're focused on improving maternal and infant health. New Jersey, I probably don't need to tell you this, but New Jersey is among the worst states in America for women of color to have a baby. Black infants in New Jersey are more than twice as likely to die before their first birthday as white infants, and Black mothers are more than 3 times as likely as white mothers to die from pregnancy-related complications. We're also focused on ensuring that all New Jerseyans are able to live in safe, affordable, and stable housing in communities of their choosing. New Jersey ranks well in terms of overall quality of life, but that belies the fact that not everyone in our state is able to live in desirable housing. We also want to ensure that we can create a more stable, robust, and public health infrastructure, and that's obviously why I'm here today. And finally, we want to invest in the ongoing legacy of our founder. Since 1972, RWJF has dedicated more than $1.2 billion toward a broad set of issues, including health, child poverty, food insecurity, civic life, and the arts, along with supporting key institutions in our home state. Many of these grants support causes that our founder, General Robert Wood Johnson, was passionate about and supported during his lifetime. These are not the only areas we know that where action is needed, but we know that RWJF is not the only entity involved in supporting health equity in New Jersey. As a champion in our home state, we participate in coalitions, collaborations, and partnerships across a range of issues aimed at making health equity a reality for all New Jerseyans. And we're honored to be among the cadre of funders who make this possible. I'm sure I don't need to tell you this, but the past 19 months has been incredibly taxing on our public health system and on our residents. The COVID-19 pandemic further exacerbated longstanding racial equities, helped illuminate the role that social determinants play in overall health, and exposed weaknesses in the New Jersey public health system. Obviously, we have inadequate public health data systems, a lack of coordination between public health organizations and community-based organizations. And as we saw, access and uptake of vaccines has been difficult for the most marginalized due to many issues like transportation, job schedules, childcare needs, et cetera. We're committed at RWJF to make sure that this public health infrastructure is strong, and the support that we provided to Jeanne and Karen at Rutgers to undertake this project to assess the challenges and opportunities associated with the structure and capabilities of local public health is a critical first step in helping to understand the landscape and what's possible. We're excited that they were able to look at our history to really do a nice analysis of what other states have been doing and to really lay the groundwork to help envision our future. The project involved 5 tasks. Again, they reviewed previous studies of public health infrastructure over the past 30 years. This isn't new for us, right? We've been at this a long time, but it's a a fantastic job that they were able to document what's been done in the past and make that transparent for all. They've examined the structure and capacity of local public health in New Jersey and compared that to 8 states. They developed video case stories, which I'm particularly excited about because being able to put this into words and video, is a great way to bring data to life and to help others understand our issues much better. And assessing New Jerseyans' perspectives of population health through the Eagleton Center for Public Interest Polling that they've done is also something that's super exciting for our state as well. I'm excited that this is the first step in virtually convening leaders to really dive in and consider project outcomes to inform dialogue for future action. This process has been very inclusive, and I'm really truly grateful to all of the out-of-state leaders who provided information about their state's challenges and opportunities, to our national partners who've helped influence this project, in particular to our State Department of Health colleagues and our New Jersey-based advisors and staff at the Eagleton Institute who really got us to where we are today. Jeanne, Karen, and the esteemed project working group that you've put in so much effort, and I'm just truly, again, grateful for all that you've done. Before I hand the program back over to Jeanne, I want to let you know that this is the first step in our foundation's investment in public health infrastructure. We're truly committed to this, and you'll be hearing more from us in the beginning part of the next year. But myself and a team at the Nicholson Foundation and the National Network of Public Health Institutes and the Department of Health have been working on establishing a public health institute in New Jersey, and we're excited to let you know about that process that led to this effort, and actually help you learn a little bit about the history of that effort as well, and release a call for applications to really get this institute up and moving in the new year. So please be on the lookout for that as well. Thanks so much for your time today. And Jeanne, I'll throw it back to you.
Thanks so much, Sallie. I really appreciate it. Hi, everybody. And thank you so much for everyone who's introducing yourself on the chat. So let's jump in. I'm going to share my screen before I start presenting giving my presentation. If you haven't seen it already, I put the website for our project website in the chat. And so this is where you'll be able to keep an eye out for final products from this project, including our final report, including the report from the Eagleton Institute on its outcomes of its polling, and other outcomes. So again, that link is in the chat. We will communicate with all of you who are participating and registered today when we're posting new things on the site. So just real quick, here's our agenda for today. What we're going to first do is myself and my 2 colleagues on the project, Karen Lowrie and Dr. Ashley Koning, will be walking through the results of the project to date. I'll give you a quick overview of the project as well. We'll take a quick bio break, and then we'll be turning it over to Dr. Anand Parekh from the Bipartisan Policy Center. The timing for our convening today is really ideal because the Bipartisan Policy Center will tomorrow be releasing its own report called Moving Public Health Forward, which has been a coalition-based national effort looking at how to modernize public health. When we get to his presentation, I will put the link for where you can register to participate in the release of their report tomorrow as well. We have 2 colleagues from other states who we had an opportunity to meet as part of this project, and they're going to talk a little bit about some of their work to enhance capacity for public health, local public health in their states. And then we will move towards a interactive conversation with our project working group with some leaders here in New Jersey who have been with us every single step of the way as part of this project in terms of implications for the findings of this work. And then finally, we'll talk about a couple next steps. Okay, so that's sort of the agenda for today. With that, I will pull up my slides. Well, hang on a second. They're not cooperating. Here we go. Okay, so back to sharing screen. As I'm pulling up my slides, let me also say that my colleague Matt Drews and Matt's here to help us make sure that the The webinar runs smoothly. We'll be monitoring the chat. So as you have questions or comments, please feel free to put them in the chat. Where am I? Okay, thank you. So let's get started. The project that we're going to be providing you an overview for, funded by the Robert Wood Johnson Foundation, and we're grateful for Sallie's commitment and hard work in leading this effort, was intended to look at capacity and structure of public health, particularly local public health here in New Jersey. And Sallie mentioned the tasks that were involved in the project, and here they are again. So what we did, which is what my colleague Karen Lowrie will provide an overview of after I talk, is we did a comparison of local public health structure and capacity in New Jersey to other states. We also looked to see what some of the efforts are nationally in terms of setting New Jersey in a national context in terms of public health structure and capacity. We looked at about 30 years worth of studies and reports and commissions that have taken place here in New Jersey, examining public health, particularly local public health. For any of the studies or reports that we reviewed, we've posted them on the project website. So that's, some of them are, 30 years old. We, as Sallie mentioned, we developed some case studies, some videos of what does it mean in terms of what does the capacity challenges facing public health in New Jersey mean here to local public health in New Jersey. And then we conducted the Eagleton poll to better understand New Jersey's perceptions of public health and their support for public health. Today, after I talk, then Karen will talk and Dr. Ashley Koning will talk, and she'll give you an overview of the Eagleton Institute poll findings. And these are hot off the press. Eagleton just came out of the field on Friday, so I haven't even seen the results. So it'll be really interesting to hear from Ashley as to what the poll results showed. This entire effort was guided by a project working group who you will get to meet and chat with later on in the session. And I can't say enough about the incredible support that the project working group gave. We met almost on a monthly basis, or even sometimes more. They were candid, they were challenging, they offered lots of detailed comments on our work, and the quality of the outcomes of this project would be nothing without their help. Okay. So let's give a quick overview of public health nationally in terms of what do we know. And first I'll start with a discussion about opportunities. So what do we know? We know that over the last several decades that state and local public health agencies across the country report an expanding role of public health, including leading responsibilities that were never originally envisioned when the nation's public health infrastructure were established. And for those of you who work in public health, this is not news to you. Examples include opioid crisis, having a greater role in addressing root causes that contribute to health inequities, whether that's community infrastructure, community violence, family and social support, food insecurity, housing instability, homelessness. These are all new challenges that public health is leading solutions in addressing. We also know that public health has taken on the responsibility for population health, including looking at solutions that address public health challenges facing whole populations, whether that's populations of people who are Black, Indigenous, people of color, people who are low income, the LGBTQ community, and others. We know that the public health community has taken on more responsibility with regard to addressing infectious disease, influenza, Zika, COVID, of course. We know the public health community has taken on a greater role in terms of use of technology to electronically survey community health and to better understand where there are challenges such as food and waterborne diseases. And then finally, we know that the public health community here in New Jersey, as well as nationally, has been leading efforts in terms of looking at and addressing the challenges to public health associated with climate change. So these concepts introduce, now my screen is freezing, introduce this concept of public health 3.0. which is a conversation that you all, if you're in public health, are involved in. And under the concept of Public Health 3.0, there's this idea that local public health becomes the leader of the chief health strategist, meaning that local public health serves as the point of contact for partnering across different sectors, whether that's food, health, housing, community planning, environment, economics, to better be able to address those underlying root causes that address health inequities. So the opportunity is that public health has taken on a lot more responsibility than originally envisioned, and that's been a very willing acceptance of responsibility. So let's talk for a minute now about some of the challenges. We heard a lot from our project working group during the course of the project about this concept of the invisibility of public health, that if something is going well, if I'm healthy, then I don't really even think about how that's being addressed. And so we spent a lot of time talking about what is public health and the invisibility that people confuse public health with healthcare often. This was one of the best ways that I found during the course of the project to better explain public health, and I've used it a lot, and we actually kind of shortened it and converted it into some language to use as part of our Eagleton survey. And again, if you're in public health, you're like, ho-hum, I know this. But in general, I think the point I want to get across here is the concept that this issue of invisibility is inextricably tied to the challenges of lack of capacity or limited capacity in terms of being able to educate voters, citizens, legislators, policymakers about the role of public health, the importance of public health, and why it needs to be invested in. So that's certainly one of the challenges that we're seeing. Another one of the challenges that we're seeing is that the public health workforce is changing. And this is a trend that's been happening for at least the last decade. A survey that was done in 2017 by NACCHO found that nearly half of government public health workforce would be leaving or retiring public health in the coming 5 years. So that brings us to our current time. And that was before some of the news that we've seen in terms of public health officials becoming frustrated during COVID. So this is a very big change in the public health workforce. We've certainly also seen that there are challenges nationally in terms of capacity. So these are just a couple studies that we've examined as part of the project. There's a classic 2003 National Academy of Medicine report, and it concluded that the United States suffers from a historic gap in priorities between investments in public health versus investments in healthcare. This committee, this National Academy Committee, also found the challenges associated with what they referred to as stovepipe or categorical funding of public health, so that funding is earmarked for specific tasks. A follow-up study by the National Academy in 2012 found, and I'll give you a little quote, that it's no longer sufficient to expect that reforms in medical care delivery will alone improve public health. This committee also found that public health and population-based prevention is the most efficient and most effective for health improvement. In 2020, the Trust for America's Health did a study where it looked at health spending and investment, and it found that about $3.6 trillion are spent on health annually, and of that, only 3% is directed towards public health and prevention. And then the Trust in 2021 updated its analysis and found that the CDC's budget fell by $7.8 billion, down 1% from the previous year, and that its budget fell 2% when you're adjusted for inflation. Finally, the Public Health Leadership Forum's study earlier this year found and concluded that there's a $13 per person gap in annual public health spending across the country. and it called for the establishment of a $4.5 billion public health infrastructure. What will be interesting will be to see what the outcomes of the Bipartisan Policy Center study are tomorrow when that report is released in terms of better understanding their updated analysis. Throughout my PowerPoint, you'll see I've got a couple little quotes in blue here from either studies we reviewed or conversations that we had during the course of this project. So now what I'd like to do is I'd like to take just a couple minutes to transition to New Jersey and give you a quick overview, in my opinion, of the essentials in terms of what we need to all have a conversation about in terms of some of these issues in terms of capacity. So again, these are the essentials. It's high level. If you're in public health, you're definitely going to tell me that I didn't get enough detail, and I'm sure I'll hear that from Paul Roman. But again, keep in mind that this is just at a very high level. So the 5 things that I want to quickly review is about local public health infrastructure in New Jersey, which seems to be a chronic conversation in the state. The issue about minimum practice standards, the role of the state health department, funding for health in New Jersey, and 30 years worth of review of public health in New Jersey. So I'm going to just go through these quickly in terms of what I think are sort of the essentials associated with these. There seems to be a lot of confusion in New Jersey. And maybe almost urban myths, urban legends, that there's gazillions and gazillions of local public health agencies in New Jersey. And I think what we were able to do is to better understand that that's really kind of not necessarily the case. Is it complicated? Yeah, it's a little bit complicated. It's no more complicated than Massachusetts, which also provides tremendous support for local public health at the municipal level in New Jersey. What this chart shows you is across the first horizontal bar is the analysis that was done by a 2008 report from the State Department of Health, at the time called the Department of Health and Senior Services. And what the chart shows is what the number of municipalities that have a local health department that only services their own municipality, municipalities that serve other municipalities, where there are regional health commissions, where there are county health departments that serve at least one municipality, and where there's a county health department that provides all services for the county. And so what we did was we took the most recent summary of public health infrastructure here in New Jersey from the State Department of Health's May report, and we looked to do a comparison. And I think the most important thing here is looking at this last column, right, which is the summary, sort of the take-home message, as to what's the percent of municipalities that participate in some form of shared services, whether that's an interlocal agreement, being in a regional health commission, or having some of their services or all of their services covered by a county health department. And what we can see is that it's a little bit more now here, 3% more than in 2008. But overwhelmingly, the numbers are tremendous in terms of the sort of approaches to shared services, approaches to collaborative efforts among agencies, and then also more formal local agreements. So this was important to me because as someone who's not a public health professional, I did come into this project thinking there are gazillions and gazillions of local public health agencies in the state. And I definitely left better understanding that this is a system that has some serious cohesion to it. Okay, so let's talk about the minimum practice standards really quickly. So you all know, if you're involved in public health, the concept of the essential public health services, right? And what we were looking at in our project working group really advised us to be careful when we were comparing to other states, that we were not comparing apples to oranges, that we needed to be cognizant of what the standards are in each of those states in terms of being able to understand what the context of the capacity was in terms of what local public health actually does. One of the other things that we did was we looked at the public health accreditation standards from the Public Health Accreditation Board. Ohio is the only state that requires local public health agencies to be accredited. Here in New Jersey, there's several local public health departments that are accredited, and the State Department of Health is accredited. But what was clear to us, and this comes from the regulations governing the minimum practice standards for local public health. This is a quick overview summary of requirements and obligations and standards for local public health in New Jersey. So what we quickly sort of really appreciated as we looked at this in relationship to the public health accreditation standards, as well as looked at New Jersey's requirements in relationship to some others, is that New Jersey's are quite comprehensive, quite broad, and really kind of on par with those national accreditation standards. So one could argue that while New Jersey doesn't require accreditation, that the minimum practice standards that are embodied in the regulations, 8:52, are in fact quite comprehensive and on par with those accreditation standards. Okay, this is a very boring looking slide. I apologize for that. So let's quickly just make sure we're all on the same page in terms of the role of the state health department, which is to monitor local health departments, which is to license health officers. So not every state requires health officers to be licensed. Here in New Jersey, we do. And to register local health departments as part of their oversight. And then to also issue, and we'll talk about this a little bit more, priority health funds, priority public health funds, and then to administer the state's public health council. So we will talk about these last two things in just a couple minutes in terms of some of the trends in New Jersey over the last 30 years. So quick, that's the role of the state health department in terms of local health. All right, now let's talk a little bit about funding for public health here in New Jersey. In 2021, as part of its 2021 update research, the Trust for America's Health found that per capita, New Jersey ranks 31st in the country for public health, and at the bottom for grant funding from the CDC. So this is important, particularly based on what I just said about the minimum practice standards, that this state has very comprehensive minimum practice standards, but that our funding is quite low. Currently, the sources of funding for local health in New Jersey come from several sources. Local property taxes, which we know is a challenge to expand in terms of bringing more capacity to local health, because no one wants to increase their local property taxes. Earmarked federal grants, and earmarked, whether you want to call it categorical, stovepiped, in terms of dollars that flow through various state agencies, whether it's the State Department of Health, sometimes through organizations like the Department of Community Affairs for funding that might be HUD, right? So these are dollars that are earmarked, whether it's for lead abatement or COVID, earmarked state funds, and then other sources in terms of philanthropic grants and other sources of funds. A 2009 self-study by the State Department of Health, actually 2008 study, concluded that local health departments in New Jersey are more dependent on local tax funds than any other state. The only source of unrestricted health dollars for New Jersey was the Public Health Priority Fund, which was a source of funding from state appropriations that came to local public health in New Jersey and was not earmarked for certain dollars, whether that was for lead or for, other purposes. So it was the only state appropriated, unrestricted source of funds. That was eliminated in fiscal year 2011 because the funding was not included in the state budget at the time, and it has not been restored. So that's an especially challenging issue facing local health here in New Jersey. A white paper by the Public Health Agencies Association's collaborative effort, NJPHACE, which many of you may be members of, indicates that state funding to health departments at the point in time when the Public Health Priority Fund was eliminated was about $6.2 million, and that would equate to about $11.2 million today. So that's a significant amount of funding that is not flowing into local public health. It's difficult for us to be able to monitor the trend in where the sources of local health dollars come from. because right now, the local health evaluation report that the State Department of Health would manage has been suspended for the last 2 years because of COVID, but also because some dollars, federal dollars, that go to local public health come through other agencies and not the State Department of Health, so such as the Department of Community Affairs. And then also because some state dollars come to local public health through other state agencies, like County Environmental Health Act dollars that come through the New Jersey Department of Environmental Protection. So it's very difficult. So you do not see on my slides a trend line that shows changes in local public health funding for New Jersey, because there is just not a source for that. Okay, so now I'd like to talk for a minute about review of public health. So what we did was we spent a lot of time scrambling around trying to find any reports, commissions, executive orders, executive reorganizations, studies that were done looking at public health in New Jersey. And this is the dozen that we identified. And again, we've posted them on the project website. So you can see that going back about 30 years, we've got a dozen or so studies that are looking at public health structure, public health capacity here in New Jersey. It's extensive. It's slightly mind-boggling, quite frankly, in terms of the amount of study that's happened in terms of public health. I would say that for many of them, the outcome is definitely the acceptance of limited capacity in terms of funding for local public health, and also the need for more unrestricted funds so that it's not just earmarked for certain purposes. I think also there's definitely some recognition in many of these studies that look at the confusion perhaps between public health and health care, and also this issue of the invisibility of public health and what's the role of public health here in New Jersey, particularly at the local level. So I encourage you to take a look at these many studies, and you'll see in our final report that we provide a pretty in-depth overview of each of them. These are just a couple quotes from some of the health officers and project working group members that we've talked to in terms of support for public health, visions of public health, frustration, I guess, with limited capacity for public health. And so you'll see on that project website that we have posted several of our videos on the website, so you'll be able to hear some of those stories told. So as I wrap up, I guess in terms of some observations on my part, personal observations, I suppose, based in part on the study, based in part on conversations with our project working group, are definitely a couple things. There's definitely is, and you'll hear from my colleague, Karen Lowrie next, that there's this sort of national recognition of the need to update or modernize public health in terms of bringing it into the 21st century, in terms of recognizing the role that public health has now taken on as the chief health strategists in communities, addressing everything from opioids to climate change to infectious disease to social determinants of health and root causes of health inequities. That we need to really be able to, and this is not just a New Jersey phenomena. And again, our timing is perfect to hear from the Bipartisan Policy Center in terms of the observations on this issue nationally. And we'll hear later today from 2 states that in terms of the work that they've been able to do. Another observation is definitely this reflection on the comprehensive nature of New Jersey's minimum performance standards, which is important to take into account as we compare other states and as we look at the challenges in terms of funding capacity here in New Jersey. We certainly see that New Jersey is especially challenged. Yes, most, all states are challenged, but we are also challenged. And I think, as you'll see from Karen, some of the other things to consider here in New Jersey is not just the comprehensive nature of our minimum performance standards, but also some of the challenges that we face as a as a historic urbanized community, highly diverse, and some of the special challenges that we face here in New Jersey. We certainly see there's been extensive study of public health in New Jersey, and some people might argue with little change or increased capacity in terms of recognition of the role of public health. And whether that's because of sort of the invisibility of public health, I don't know. That would be speculation on my part. As you'll hear, we've also heard from other states that they've really begun to be able to start to address some of these capacity issues, and how they've done it is, I think, a really interesting story. We'll have videos from some of those other states on our website, in addition to two other states joining us here today. And one of the things that we heard overwhelmingly from other states, from public health officials here in New Jersey, was how COVID really exposed and laid bare the challenges of public health capacity, particularly at the local level here in New Jersey. That it really provided the evidence of the need for greater capacity in terms of public health, and flexibility in terms of public health for local health officers who will tell you that they know their communities the best, to be able to be flexible and to be able to take on new challenges to support their own communities. And so as a result of that, I think what's interesting to me as we think about this package of observations is the one piece that I can't speak to you yet because we haven't heard the results on, is how do New Jerseyans view public health? What do they understand about public health? And what's their support for public health? So we'll be hearing about that from Ashley Koning when she talks about the Eagleton results. But I think what's interesting is to think about some of these observations in light of what do New Jerseyans think about public health, and how do they support public health? So how do we start to move forward in terms of this concept of modernizing public health, bringing public health into the 21st century? Understanding how New Jerseyans look at public health is a critical aspect of that, which is why we conducted the Eagleton survey. Okay, so I'm wrapping up here. So next steps, so I'll be turning it over to Karen, and then we'll be turning it over to Ashley. We'll take a quick bio break before we hear from the Bipartisan Policy Center. After today, we will be finalizing the report from the Eagleton survey, and that'll be just over the course of the next week. We'll be finalizing our own project report. All of those reports will be put on our project website, and we'll shoot all of you who have participated or who registered for this webinar. We'll send you an email to let you know things are posted. We're also going to send all of you a link to the poll that we conducted with Eagleton, because we would like you to take it so we can compare your perceptions and your perspectives with what we heard statewide. We'll also be doing outreach and trying to do more education to decision makers and policymakers and others about what we've learned as a result of this project. So thank you very much. I'm going to turn over to Karen and Ashley, and then at the end of our panel, we'll see if there's any questions. So Karen, I'm going to stop sharing here, and I'm going to bring up your slides, and I will go off video.
Okay, can you hear me?
Yes.
Yes.
You're good.
Okay. I'm going to wait for the slides to come up. Okay. I'm Jeanne's colleague, Karen Lowrie, and I'm here to present this phase of our study. At a high level, there'll be a chapter in the report that has more detail about this analysis. The idea of this phase of the study was to provide more context for understanding New Jersey's public health by looking at models and examples from other states. So we conducted a comparative analysis of other state public health capacities and some of the demographics and efforts that they have undergone. And it had two two parts. One was the comparative analysis of data and statistics, and the other was mini case stories based on interviewing public health leaders in the states and supplementing with other information that they pointed us to on their state websites. Next slide. We selected the states based on those that were known to have begun some type of capacity building effort in the state. And then we put a priority on some states that were closer politically to New Jersey for comparison's sake, or geographically to New Jersey. So we refined the list in consultation with the project working group and came up with these 8 states. Some of which are close in proximity and some which are not, but who that had modernization efforts that we wanted to find out more about. So next is a very small print table. I apologize for that. These will be in the report. Some of the summary points from the demographic and socioeconomic profile comparison are that in the red on the right column, New Jersey is by far the most densely populated state, which is not a surprise to most of you on the call. About 40% more densely populated than the next closest state in our list, which is Massachusetts. And as Jeanne mentioned, New Jersey also has the most diverse population, in that it's the only state of the group that has more than 10% of the population in each of the Black, Hispanic, and Asian demographics. Not the highest in each, but has a more spread out, diverse population among minority groups. It's around the middle in percentage of very young and very old. And it's most similar in median income and poverty to the geographically closer states like Connecticut, Maryland, and Massachusetts, but as noted, is much more racially diverse than Connecticut or Massachusetts. So it's got that mix of a lot of diversity. It's been called sort of the haves and have-nots, in that, the poverty level is not as low as some states. Median income's a little higher, but there is that diversity and dense urban population. Next. We also compared what are considered the basic services provided by local public health in these states. It's called, the state efforts have labeled them differently, whether they call them foundational services, basic services, essential services, core services, and the list of how they've broken out the public health services ranges from either a list of 5 core services up to a list of 12 from these states. But the commonalities that all the 8 states plus New Jersey included were environmental health, communicable disease prevention, and then some type of a general population health tracking or assessment function. Some of the other included services are emergency services, maternal and family, vital records, and others. But they go by different names and are sort of classified differently in different states. And again, it's important to point out, as Jeanne did, that all of them are also included in New Jersey's public health practice standards, but not necessarily categorized in the same way. And regarding structure, among the states we looked at, there was quite a variance. The number of local health departments varied from 24 in Maryland, which are county-based plus Baltimore, to over 350 in Massachusetts, which is all municipal level. Next. This table is very hard to read again, but the point here was to look at the Trust for Foundation for America's Health, TIFA, and the NACHO data the city and county health officers' data to look at support for public health and funding. And it did show New Jersey highlighted in the right column there that New Jersey and Massachusetts both had the lowest local appropriations for public health per capita among all states. And for state appropriations, New Jersey, as we've noted, was the lowest among all the states. But interestingly, all the states except New York did show a decrease from 2013 to 2019 in state appropriations. New Jersey had the second lowest total revenue. So looking at all revenue, a median per capita. And Maryland kind of comes out the winner, having the highest total revenues for public health and state appropriation and local appropriations per capita. The bottom row shows public health workforce, and New Jersey is also among the smallest workforce per capita and it only has half the workforce per capita of Connecticut, Maryland, Massachusetts, and Oregon, for example. Next. So just we want to go into the second part of our analysis, which was digging a little deeper into the comparison states. And you're going to hear in more detail the stories from Connecticut and Washington. So I won't touch on those at all, but we just wanted to point out a few of the highlights from 3 of the other states that we talked to. This one is Maryland. Maryland, which has the smallest number of local health departments that are all county-based plus the city of Maryland, but provides state funding to local health departments. It's called the core funding, C-O-R-E, the core funding, through legislative appropriation. And it does provide a base amount of funding to support a minimum public health department. They've got 7 core services that are state funded with a county match. And there are 2 current bills that would formalize this core funding and tie it to the consumer price index so that it would keep pace with other budget funds. The thing about Maryland that was striking too was that the public health sector benefits from what they consider public positive media coverage from the local press and the larger DC area media. And this graphic is on their webpage. It's something that they put out, that sort of a professionalized PR effort to explain the mission of public health and the importance of the support for public health and what it does. Next, just a little bit about Massachusetts, the most decentralized system, but in 2016, the legislature created a special commission on public health that issued a blueprint report in 2019. And this special commission formed the basis of the adoption of what is called the State Action for Public Health Excellence. This is a legislative briefing sheet that was used to support the adoption, promote the adoption of the program. It was a series of reforms. Again, this is part of the fact sheet for the program. And a key lesson from Massachusetts was the presence of legislative champions to push this forward. They're now moving forward with the funding, starting with $10 million that was appropriated this past year. The Health Officers Association now is lobbying to bring it to $20 million for the next fiscal year. And next, Oregon, which has a fantastic website with a lot of graphics like this on it. We just wanted to show that Oregon has an official, public health modernization program, and with legislation from 2013 that created a task force on the future of public health. So they were a little bit ahead of the game versus other states. that studied and began the modernization study, so almost 10 years ago. And this task force determined that the foundational services that were not funded at the time, but that did serve all Oregon residents. And so the analysis pointed to an over $200 million gap between what it really should cost to provide those functions and what the current level of support was. So after that task force report, they did some polling, and the result of all this work was a 2015 law that used the Institutes of Medicine framework that is shown here about foundational programs and foundational capabilities, and the legislature approved $5 million in 2019, and then an additional 10. And currently the public health community is requesting 70 million, and the administration appears to be supporting roughly half that going forward. So next, just to emphasize that we heard a lot from the other states that supported what we found from New Jersey as well, that it's not just New Jersey's issue, it's nationally that, public health works behind the scenes. There's an invisibility issue. When a disaster happens, people then maybe cry out for a public health presence, but they don't really realize what public health is doing all the time. And if we want to make it more effective, that, we do need to invest in it. So those are some direct quotes. And then finally, next, what are some of the key themes and lessons? We highlighted these 5 key messages that come out of this comparative research that can be used to develop recommendations for building capacity in New Jersey. One is that all of the states we looked at took on an effort to identify core, basic, or foundational services and do some type of an assessment of the needs and gaps. Developing this consistency around a set of core services then allow the cost to be attached to each, and then facilitated like a more clear discussion around what resources were needed to sustain those services. Second, in other comparison states, the efforts generally led to increased capacity because they focused on a smaller set of priority outcomes rather than a large kind of broad general reform measure. Third was the securing stable unrestricted funding. Some states had some level of it to begin with, some had none, and just getting it in the recent budget cycles. But all indicated that a part of the effort, a major part, was that stable unrestricted state funds provide the opportunity to have that flexibility to respond to local public health challenges, to build partnerships, and just to ensure follow through on all the initiatives and services of public health. Forming collaborations was key. Efforts to advocate for modernization benefited greatly when various agencies and associations with public health missions joined together, pooled resources, built stronger capacities. You'll hear about that later from the state representatives that will be joining us, either formally or more informally through looser collaborations. Those collaborations also then benefit from legislative champions, of course, who can push the agenda forward. And finally, in several of the states, and primarily those that had formed a strong collaboration, there was an ability to really promote more of a PR, a public relations standpoint, the functions of public health and lobby more formally for public health, and in a more professional way through briefing sheets, broadcasts, website information using local media and social media, even to build public awareness. So with that, I thank you for your attention to this part of the study, and we'll move on to the next presentation. Thank you.
Thanks, Karen. Thanks so much for all your hard work. I would now like to invite Dr. Ashley Koning, who's the director of the Eagleton Center for Public Interest Polling here at Rutgers University, to join us and walk us through the results of the recent, just in the last week or two, polling of New Jerseyans. Ashley, are you there?
Yep, I'm here. Hi, everybody. Good morning.
Hey, how are you? Good morning.
Good, thank you. Alrighty, so Jeanne, you want me to just take it away?
Go for it.
Okay, great. Thank you. My colleague Jessica Roman and I were saying that we needed to have little newsboy caps and shout, hot off the presses, because these results are literally hot off the presses, especially with the holiday season. We literally just pulled out of the field. So this is fresh data on New Jerseyans' perceptions. I'm going to share my screen, which I feel is something all of us say every single day whenever we have these Zooms. So let me just enlarge my PowerPoint. Okay, so hopefully everyone can see.
Yes, you're good. We can see, Ashley.
Fantastic. All right, so let's take a look at the data. So we worked with Jeanne and the working group, Jeanne, Karen, and the working group. And first and foremost, we were so happy to be a part of this. So thank you to Jeanne, Karen, the group, RWJ, for including us in this. This is right in the wheelhouse of our public mission. We're actually, as a center, as part of the Eagleton Institute of Politics, we're turning 50 years old this academic year. So the center itself is 50. The center in particular, much like the Center for American Women in Politics, we are the two oldest centers at the Eagleton Institute of Politics over on Douglas campus at Rutgers. Moreover, the Eagleton Center for Public Interest Polling is actually the oldest statewide university-based poll and survey research center in the country. So we're very fortunate to have a very long and large legacy behind us, and the longest continuously running survey center in the country because of that. And actually are fortunate to have kind of birthed multiple other polls of this kind of similar nature around the country in other states at other universities, kind of being the catalyst for them. So we've been polling New Jerseyans literally now for 50 years. And it's always interesting and incredibly informative, and with our mission being putting good back into the public dialogue and putting data, objective data back into the public dialogue, it's always fascinating to do studies pertaining to such important issues and topic areas that, as I like to say, in kind of a romanticized view of polling, never really get their day at the ballot box. And yet these are issues that are just as important. So we worked with the group on crafting a questionnaire designed to assess kind of a baseline of where New Jerseyans are in terms of their perceptions of public health, their awareness, their perceptions, their attitudes towards it, particularly with a focus on their local public health departments. The survey was conducted mainly by telephone. We had just over 1,000 New Jersey adults who completed interviews with us, 18 years or older, with a margin of error of 3.5 percentage points, which is including a design effect of 1.31. The survey was conducted between November 19th and the 28th. So like I said, literally just out of the field, and waited for all of you to consume. This was a dual frame telephone survey conducted by both landline and cell phone, in accordance with the kind of the appropriate proportions nowadays, given the high cell phone mostly household rates within New Jersey and nationwide. A small portion were conducted by live interviewer texting a push to web link from the same cell phone sample frame. So there were also a small portion of one-to-one SMS messages sent that pushed respondents to the web. Again, same cell phone numbers as our cell phone sample frame from the survey. Demographics mirroring what we see, likely see from census data parameters in the population in terms of making sure we have representativeness on age, gender, race, and partisanship in accordance with how they're represented within the New Jersey statewide population, as well as region and so on. Given that these results are hot off the presses, I'm going to take a look at go over the marginals of each one of the questions we talked about, all of the demographic breakdowns, including what we consider to be statistically significant relationships, and differences between demographics will be included in the final report next week. So we started out by talking about healthy lives and what are some of the health problems that New Jersey currently faces. And so New Jerseyans were asked what was the top health problem in the state according to them right now. If you saw recently, we actually asked, we've always asked the most important problem in general in the state. And so if you saw one of our headlines recently, no surprise, taxes is the most important problem in general. And this has been the most important problem for the past 50 years. In our very first poll, taxes was the answer as well. But this time around, we specifically asked about the top health problem. This is a word cloud of actually all of the verbatim responses that respondents gave us. These responses will be quantified and categorized and quantified in the final report to see what pops out the most. But yeah, as you can see from the word cloud, there are themes including, obviously, first and foremost, COVID. This was something throughout the survey that we made sure to remind the respondent that we wanted to assess public health kind of in addition or besides COVID, putting COVID aside momentarily and talking more about public health in general. But of course, this is at the top of New Jerseyans' minds. So this is something that they're going to continue to think about and continue to answer based on the current environment. And so COVID was a big health problem that came up in these responses, as well as flu and cold, talking about healthcare, whether it be access or quality, obesity, mental health issues, drug addiction, affordable housing, pollution, poverty, clean water, racism, cancer, food insecurity, all major themes. And you can see a couple more of them popping out. Obviously, the bigger the word, the more it was likely mentioned by a respondent. We see pollution in there, diabetes as well. These are a lot of the main themes that were top health problems or considered to be top health problems among respondents in New Jersey when asked about what they thought was the top health concern in the state. We then asked them how much responsibility they thought each of the following has in making sure people lead healthy lives. This is no surprise that most people thought individuals should have the most responsibility. 72% say that individuals should have a lot of responsibility. Almost all said that individuals should have at least a little, if not more, responsibility. So really, New Jerseyans perceive for as left of center as New Jerseyans are on social issues in the state, they really do perceive that there's a large amount of responsibility on the individual for leading a healthy life. A very distant second and third being the state government and business and industries. We see that, respondents say, about just over half, or about 6 in 10 rather, say that the state government has some or a little responsibility. Business and industries actually even slightly higher than that. Local government around the same, about 6 in 10, almost 2/3 saying that local governments have a lot or some responsibility. And then finally, community and faith-based organizations, just 22% say they have a lot of responsibility and 31% say they have some responsibility. So community or faith-based organizations being the group that we asked about, that individuals thought they should have the least amount of responsibility for helping people lead healthy lives. We then started to tease out what exactly does public health mean to New Jerseyans. And so we asked them for a definition. Again, this was a baseline survey. And while there are surveys out there assessing perceptions about public health, they're limited. This was really, primarily a work from scratch. And when you start with something like that, It's actually just simply asking verbatim what respondents think about some of these issues. And so this will be another fascinating one to get through in terms of when we categorize and quantify it, as well as demographic breakdowns, how New Jerseyans define public health. Again, the larger the word, the more likely that word popped out in the verbatim responses. In terms of general themes, we saw a lot of responses that created some sort of definition pertaining to the health of the population, health services and programs, equal access and affordable health care, the government response to healthcare issues, health issues that impact a society, informing the public about health issues, the science related to health, individual healthcare outcomes and responsibility, environment, infrastructure, a minimum standard for health that's mandated, and community response to health and taking care of each other. So some kind of awareness about what public health actually was. One of the most enlightening things for us at the Center for Public Interest Polling was actually learning in depth about what public health was. And again, we are so grateful to be a part of this and to really take a deep dive into public health, because we know it is such a massive term. So New Jerseyans claiming to have a bit of a good grasp on what public health actually means. And they feel like they have this good grasp. When they're asked if somebody read or if they heard or read about public health, how well do they understand what that means? 35% say very well, 44% say somewhat well, with the minority not understanding it as well. So really, again, New Jerseyans perceiving both in the definitions they provided and in an assessment of their own knowledge that they actually know what public health means. The definition on the right is what we actually used in the survey moving forward to tell them to kind of think about when they're thinking about public health. Half say that they're familiar with local public health departments and what they do. 12% say they're very familiar. 38% say somewhat familiar, although that other half, of course, with most of them saying not too familiar at 30%, have some level of uncertainty about what local public health departments do. So even though New Jerseyans seem to have a good grasp on what public health is, there's not as much of a grasp on what local public health departments do. And relatedly, New Jerseyans are torn between thinking whether or not local public health departments do enough, do just the right amount to help people lead healthier lives, or whether they do too little, each at 35%. Just 7% say they do too much, and 23% don't know. When we talk about what the main responsibilities are for local public health departments, and we ask New Jerseyans to say whether or not they thought each of these following items were a main responsibility of local public health departments. As we can see, New Jerseyans are most familiar with or believe that disease, emergency preparedness, and food safety of some sort are the main responsibilities for local health departments. 8 in 10 or more of New Jerseyans mentioned these 3 top items. The items decline slightly from there, but well over a majority says that each one of the following are a main responsibility for local public health departments. Looking about 3/4 say environmental health, clinical services, and health and nutrition education. About 7 in 10 say maternal and child health, and 6 in 10 say animal control. Taking those same items throughout actually the next 2 questions, we asked what the most important services that their local public health department provides. And far and away, we can see that 28% said the most important service provided is infectious disease prevention, monitoring, and reporting. Of course, this is most likely, again, due to COVID, even though we said to kind of put COVID aside throughout the survey. This is clearly on the top of New Jerseyans' minds, clearly one of the most prevalent things, least prevalent being animal control, environmental health, and maternal and child health. And in fact, all of the rest of the responses are in the either low to high teens in terms of the most important service that New Jerseyans perceive. About half say they've been personally impacted by local public health department services, and almost half say they've actually contacted or engaged with their local public health department in some sort of fashion, whether it was through a health event or fair, service or training, educational materials, or in some other way. Once again, most, just over half, say that they've been personally impacted by infectious disease prevention. Quite frankly, I'm surprised these numbers are as quote unquote low as they are. I would think most people are affected by most of these things. But what's interesting here is the individual perception of New Jerseyans thinking whether or not they've been impacted by this. About half say the same, that they've been impacted personally by food and safety and emergency planning. Around 4 in 10 say the same about clinical services and health and education, environmental health and animal control, and about 3 in 10 in terms of maternal and child care. The big one, talking about public health funding. New Jerseyans want stable funding. Of course they do, for local public health departments. 59% say it's very important. Another 29% say it's somewhat important. But here's the bad news. They don't want to pay for it. This is something that rings through every single issue we talk about, whether it's other economic issues on the table, whether it was us talking about the Transportation Trust Fund a few years back, whether it's us talking about the Affordable Housing Trust Fund. New Jerseyans are so overburdened by taxes that they simply do not want to pay for services that they know need permanent funding or established funding or secure funding, and services that they need. So again, we see that here when we asked about 3 different items, either a small increase to their income or property tax, or a small tax on unhealthy food or sugary drinks. As you can see here, the winner, of course, is just over half support in some degree doing that small tax on unhealthy food or sugary drinks. We see very little support for a small increase in property tax, as well as a small increase in one's income tax. So again, New Jerseyans, and this is a theme throughout many topic areas, putting the onus on someone or something else instead of themselves in terms of being burdened with any higher type of cost. When it comes to who they seek out public health information from, far and away doctors and nurses are the sources from which they seek out the most information, 67%. Far and away, this is the highest one. In a distant second, we see, and third, we see the state health department and the local health department when we're talking about being very likely. But when we add in those answers of somewhat likely, we do see that, about 2/3 say they would be very or somewhat likely to contact the state health department or the local health department. Family members and friends follow up next. This is always a high category. We actually have asked this question about health information in general, and very similar patterns have fallen out, and there have been very distinct demographic breakdowns as well with this question, especially among race and ethnicity, in terms of which sources they go to more or are more likely to go to. We see that 25% say that they would go to some sort of media source. Another 32% say they would be somewhat likely to do that. A decent amount, half, say they would be somewhat or very likely to use the internet or social media platforms. And even a notable number of 15% very, 32% somewhat likely would go to a community or faith-based organization or public community center. The numbers look very similar when we're talking about who they trust for public health information. So not just who they would go to, but who they would actually trust. Again, far and away, 7 in 10 say they would trust a doctor or a nurse a great deal. Another 25%, meaning almost everybody, would at least trust a doctor or nurse a moderate amount. Still, pretty high ratings for the state health department and local public health department. Almost 4 in 10 trust each of them a great deal, and 4 in 10 trust them a moderate amount. So you have about 8 in 10 saying that they, to some extent, would trust the state or local health departments to give accurate public health information. Again, high numbers also, though, for friends and family. About 7 in 10 say they trust them a moderate or great deal. Newspapers, television, magazines, just over half would trust them a moderate or great deal. Same with community or faith-based organizations. Internet and social media platforms, this time coming in last, just 10% would trust them a great deal, and 25% a moderate amount. Like Jeanne had said, we'll have a report on this with demographic breakdowns out next week. Please feel free to contact us either in the interim or after, but this was kind of the preliminary breakdown of the results, and hopefully it was insightful and created a good baseline for assessing perceptions and attitudes of New Jerseyans on public health issues in the state. Thanks so much.
Actually, thank you so much. That is so incredibly interesting. I want to respond to a couple of the questions in the chat, and then we're going to take a quick bio break. Actually, one question was, this is, I think, probably a crystal ball question for you, quite frankly, is whether we could expect that some of the results would have been different had we done the survey prior to COVID.
I think I would say infectious disease obviously is spurred by COVID, and we need to look at what the definitions say, what the verbatim responses say about the definition and the top health problem. But I still think, at least my gut reaction would say, it would still be kind of towards the top. I think that's something that's most visible. We talk about the invisibility problem of public health, and really that's when public health, I feel, is most visible. And so, I think it shows, COVID or no COVID, a lot of these issues that public health departments engage in are still just not on the radar, whether COVID exists or not.
Thanks. I think also, as I looked at the chat, there's, I think, a lot of reflections and conversation and not so much questions, which is great. And again, I'll remind you that in a little while this morning, we'll actually be having a conversation with our project working group. And that'll be a time we can bring up some of these issues and all of you can bring them up. Clearly, one thing that we see from some of the comments in the chat is some of the challenges in terms of the public understanding the role of public health, particularly with regard to public health in the community and addressing root causes of health inequities and social determinants of health. So that's clear to me too from the chat and the poll results as well. Actually, there was one question, which I think the answer is no, is to whether we asked a question rather than just about increases in taxes, about whether people would support shifting taxes, tax burdens from other areas to support public health. I don't think we asked a question on that.
No, we didn't. And I think that would be something great for future surveys, especially as plans form more. I think, with public opinion, you always want to present some sort of trade-off, because of course, the ambiguity of, do you want to pay more? Nobody's ever going to want to pay more. So I think, as public health evolves down, a new chapter, thinking about what are those trade-offs and teasing that out a little more among the public.
Yeah. So just a couple of things I saw in the chat. Yes, we will be posting the slide decks on the project website. Again, we'll send anyone who's registered a notice when things are posted. Yes, no one wants their property taxes to increase, and that is a challenge given that is a major source of funding for local public health in New Jersey. There was a question about can we get more details on the comparison to the other states, and you will find that in the final report. Our expectation is that report will be available the end of next week, not the end of this week. So it's almost done. We'll be adding in the results from Eagleton into that again. So there'll be more details there. And there was also a question about better understanding kind of messaging and communications in terms of what works in other states. I think we'll hear a little bit about that after the break when we have representatives from 2 other states joining us. But then also that's also another topic that we go into fairly in depth in the final report, and we just don't have time to get into today. So with that, I am looking at my clock, and I see that Dr. Anand Parekh from the Bipartisan Policy Center has joined us. So here's what we're going to do. We're going to take an 8-minute bio break, and we are going to come back punctually at 10:30 so that we can hear about the work from the Bipartisan Policy Center that's being released tomorrow. I will put in the chat the link to where you can register if you want to participate in the Bipartisan Policy Center's release of its report tomorrow. I'll do that now during the break. So I will see you. My suggestion is that everybody just, I'm going to go on mute and off camera, and we'll see you in 8 minutes max. See you then. Okay, everyone, why don't we get started? Hope everyone had a good quick break. I see we have a lot of folks who are back, which is terrific. So for the remainder of the morning, I'll be turning it over to Dr. Anand Parekh from the Bipartisan Policy Center, who will take about 20 minutes to walk us through the results of the Moving Public Health Forward national initiative that the Bipartisan Policy Center has been leading, which again is being released tomorrow. And in the chat, I put the link to the site where you can register if you want to participate in the release presentation. That'll be followed by representatives from 2 other states who are joining us to talk about their experiences. And then we'll have an open conversation towards the end. So I hope that it makes sense to everyone. And with that, I am so very happy to turn it over to Dr. Anand Parekh, who will walk us through the work of the Bipartisan Policy Center. I think it's just so timely that this work is coming out at the same time as our work. So I think I'm very interested to see how the national perspective has synergies with what we've learned here in New Jersey and the results of our work. So hopefully that'll add to the conversation here in New Jersey as well as to nationally. So Anand, I'll turn over to you.
That sounds great, Jeanne. Well, first off, thank you for those kind words and that kind introduction. It's great to be with all of you today. I've had the opportunity for the last 45 minutes or so to sit in, and I just want to say that I wish every state was doing exactly what you all are doing. I think New Jersey is a leader in that regard, but the polling data, so fascinating. I think the discussions you all are having in assessing local public health capacity and the infrastructure is so important right now, trying to identify funding. So critical discussions, and thank you for the state's leadership, the Rutgers RWJ Foundation for supporting, and all the partners, individual and organization, public health leaders in New Jersey for coming together. I'm honored to spend some time with you this morning to talk about what we think is an important national effort that will be unveiled tomorrow, entitled Public Health Forward. As way of introduction, as Jeanne said, my name is Anand Parekh. I'm the Chief Medical Advisor at the Bipartisan Policy Center. The Bipartisan Policy Center is a nonprofit organization in Washington, D.C. that tries to take the best ideas from both political parties to promote health, security, and opportunity. It was founded 14 years ago by 4 former Senate Majority Leaders, 2 Democrats, 2 Republicans, and covers an array of domestic policy issues. Health is our largest issue that we focus on, and I provide the clinical and public health expertise there. About 6 months ago, in partnership with a number of organizations, we launched an effort entitled Public Health Forward, Modernizing the U.S. Public Health System. Next slide, please. And the intent was really to articulate a 5-year vision for governmental public health in the United States, and an actionable framework for state and local elected and health officials to reach this vision. So the organizations involved include, as you would expect, ASTO, state leaders, NACCHO, in terms of local, county, and city leaders, Big Cities Health Coalition, Public Health Accreditation Board, as well as a number of national philanthropies. Now, this is somewhat of a novel effort for the Bipartisan Policy Center. We usually are focused at the federal level in terms of educating, informing Congress as well as the executive branch. But here, the focus of Public Health Forward and identifying a future vision was really focused or is really focused at the state and local level. So the key audience here are state and local elected officials. So we're talking about governors, we're talking about mayors, county commissioners, state legislators, as well as then state and local territorial health officials. And the actions, which I'll speak to in a few minutes, really are specific to both of those groups. It's going to take actions from both elected officials as well as public health officials. And the 2 of those groups working together are going to be critical. So that's really the focus. The question of why now, why launch this effort, Public Health Forward now, why launch an effort to articulate, come to consensus nationally on a 5-year vision for public health and design actionable framework? Well, I think as most of you would probably answer the question the same way, I think COVID and this once in a generation, if you will, public health event has really brought public health to the forefront. And bringing public health to the forefront has also brought with it an infusion of significant short-term funding. And now I'll get into that a little bit. Of course, this short-term infusion of funding is time limited. It is focused on COVID, but it is a significant amount of money. And so part of the impetus for this project was to provide a framework for elected officials, for public health officials, to be good stewards of those important dollars, billions of dollars flowing through the 5 COVID relief packages, the American Rescue Plan, across many, many different areas, from surveillance to lab capacity to workforce, obviously vaccines and testing in many, many different areas. Now, I think we all realize that even though the short-term investment in public health is important, it's still not the long-term sustainable investment that public health needs. And I think you all have already talked about, based on the best research with respect to costing out the foundational public health services, we're at a gap in this country of about $34 a person. So that's over $10 billion annually that we're short, about half of it that would need to go to foundational public health areas, the other half that would need to go to foundational public health capabilities. I will say that in the Build Back Better legislation currently being debated in Congress, there is somewhat of a down payment in there, about $7 billion over 5 years, that would go to enhance the public health infrastructure and public health capabilities. It's unclear whether that'll ultimately make it through and what will happen with that legislation, but there is at least some discussion in Washington, D.C., which I think is a good sign. I think it's a good sign that people are realizing that public health has to be considered part of our nation's infrastructure, just like we think of other important elements. So that's really one impetus. I think the second impetus of Public Health Forward is really what we've gone through with COVID. And while I think more Americans have a better understanding of what public health is, as I think we saw from the survey data just presented, it's also coming at a time where the response to COVID-19 has been quite politicized. And unfortunately, public health has therefore been politicized as well. And I think we've all lamented, as we've seen, the resignations and threats and the firings of public health officials across the country. And I think that's worrisome. But it also provides an opportunity for us, an opportunity to excuse me, to redefine what public health is, or for the first time define for many people who don't know exactly what public health is and its important role in society. So that's really sort of the background of why we launched this project. Next slide, please. So the leadership of Public Health Forward comes from, and this is what the Bipartisan Policy Center does often when we tackle important public policy issues, we put together a bipartisan task force. And we put together a task force of current as well as former elected officials at all levels. So governors, mayors, county officials, state legislators. But we also made sure to include other representatives and leaders of different sectors who are important partners of public health. Ultimately, I think we all would agree that public health is not just public health's responsibility, it's everybody's responsibility. And that's why we have business leaders on this task force. We have faith leaders on this task force. We have healthcare leaders on this task force as well. So it was a diverse task force, 14-member task force that led the project. But around this task force was a national group of about 25 public health experts who formerly also had leadership roles, many of whom in government at all levels, who provided a lot of the expertise. We also, over the last 6 months, held 6 roundtables in a number of areas, which I'll get to in a moment, where we convened experts to talk about opportunities and challenges for public health. We also put together a number of roundtables, as well as focus groups, had a number of surveys as well. I think one of the important themes here is we didn't want this to be just another effort, top-down, led from Washington, D.C., yet another report. We really wanted this to spotlight the comments, the feedback and thoughts from the front line of public health at the local level. And that's why we tried to make sure that through our surveys and focus groups and other efforts that we obtained information from leaders who are really on the front lines in terms of where public health needs to go. And so over the last 6 months, we really put all of that information together, and through the task force's leadership, we're able to put forward a vision, a framework, and then a concise number of actions for state and local elected officials and public health officials. And that's what will be released tomorrow. And so what I'll talk about for the next couple of minutes is just sort of a sneak preview of what you'll hear about tomorrow, as well as what you'll read about in the full report released tomorrow. Next slide, please. So the vision, again, is 5 years. So it's 2026 that the United States is a healthier nation because elected and public health officials seize the historic opportunity to invest in new and transformative ways to modernize the governmental public health system. The vision really focuses in on health equity and the need to ensure that everyone has the opportunity to attain a maximal state of health. And that is only possible through partnerships, whether it's with sectors like housing and nutrition and transportation, whether it's through partnerships with stakeholders such as the business, faith-based, or healthcare communities, as well as community engagement. It's not what we do for the community, what we do for them, but it's what we do with them. Sufficient, predictable, flexible public health funding, which we'll talk about, critical there. You all have already talked about that this morning. A robust, modern, interoperable, and secure public health information system. Public health data, unfortunately, in many regards, is not up to par. And we certainly need updating there. Modernized laws, policies, and statutes. We've unfortunately seen in many states, and at least in 10 states, some laws passed limiting the ability of local public health officials to really do their job. We've seen preemption-related issues as well. And so in a healthier America, modernized laws, policies, and statutes would protect and promote the public's health. And then, of course, we need a highly skilled, trained, and diverse public health workforce. The latest estimates that we've seen from the de Beaumont Foundation and others who released the Staffing Up report is that we need an increase of about 80% to our public health workforce. It's about 80,000 new individuals. And I think we all know over the last 10 years, we've had a significant reduction in the workforce between 2010 and 2020, even before COVID-19. And so, again, these were the critical elements that the task force thought what were essential to coming up with a forward-looking vision in 2026. Next slide, please. Behind that vision is essentially a framework. Well, how do we really achieve that vision? And how do we advance health equity in a way that reimagines the way public health departments work? And the task force ultimately honed in, again, with health equity at the center, 6 areas. And these are not surprising. You've talked about most of these already this morning. The importance of financing, laws and governance, community engagement, partnership, workforce, and data and information technology. And the idea is that if we can come up with a concise set of actions at the state and local level that both elected officials and public health officials can focus on, and certainly those actions are going to be different, then we'll be able to collectively move towards this vision. So I want to just take a couple of minutes and run through each of these six areas. Next slide, please. So with respect to financing, I think we've talked about nationally the gap that we have in terms of meeting the foundational public health services, both areas as well as capabilities. We know that we're going to need federal leadership there. Federal funding is going to be absolutely important. But the actions within the finance section really focused on what state and local elected officials and public health officials can do now, leveraging the recent federal investments, also utilizing options at the local level and the state level to increase financing for public health. And the actions, again, for both elected and health officials focused on providing flexible funding, so moving away from categorical funding, maximizing existing assets to support public health services and capabilities. Some of this gets at at looking at ways where we can blend and braid funding, whether it's public and private sector, whether it's across state government, blending funding where it's all coming into a pot, braiding funding where you can still identify the initial streams, but really providing flexible funding, maximizing existing assets to support public health services and capabilities. And then also ensuring that we can better articulate the impact of these public health programs and strategies. And sometimes we're so focused on implementing the work of public health that we then don't spend as much time either communicating or evaluating and telling people the stories of how important that work is, either in averting illness or disease or in promoting good health. Now, part of I think the process of providing flexible funding and maximizing existing assets is to do what you all are doing in New Jersey. Many states are already doing, taking the tool, the foundational public health services, and costing out exactly how much is currently going to public health and how much should be going to public health, and understanding what that gap looks like and where that gap is. And here's an example of Ohio. Ohio is one of many states that did exactly this in 2019 to find about a $45 million gap in terms of what it needed to spend to ensure the conditions of populations can be healthy and what it currently spends. So that's a first step here, and I think that's something that every state in the country needs to be doing. Next slide, please. The data and information technology actions really focus around two things. One is the bidirectional information flow of public health data from local, state, and federal public health. And again, it goes both ways, as well as the second action of data sharing between public health as well as healthcare. And I think we've seen a big limitation during COVID-19 with respect to many issues, one being race and ethnicity data with respect to testing as well as vaccines. Here's an example from Oregon over the last couple of years, where the Oregon legislature passed a bill requiring that healthcare providers collect information on race and ethnicity and share this with healthcare and public health authorities. We don't really have this in every single state, but again, that bidirectional information flow from local, state, and federal, just public health, and then healthcare to public health, electronic case reporting is one important example, is extremely important. So there are a set of actions both for elected officials as well as public health officials in this area. Next slide, please. Workforce was a third area, and the overarching actions here focused on investing in the recruitment and retention of a diverse and inclusive governmental public health workforce, which initially has to include an assessment of what does the current workforce look like right now? What do we need in a state or in a jurisdiction? And then how do we get there? What do the pipelines look like to get there? It also involves improving hiring and promotion policies and processes to ensure high quality public health services, whether that's ensuring that there's competitive pay, ensuring that there's merit-based pay. Here's an example from the state of Tennessee, who a number of years ago established a pay for performance program. They created a position of chief learning officer to direct professional growth and build a learning environment. We heard a lot about that as well, the need to ensure that there's a learning environment to support state employees and public health officials as they grow in their jobs as well. So civil service reforms, competitive salaries, pay for performance, creating a learning environment, all critical aspects of enhancing the public health workforce. So again, there are sub-actions for both elected officials and health officials articulated in the report. Next slide, please. The fourth area is public health laws and governance. And here the task force felt strongly that every state, particularly given COVID, needs to review and evaluate modernized public health governance structures as well as statutory responsibilities. Here we point to an example from Indiana that recently put together a governor's public health commission to examine the state's preparedness for health emergencies, funding plans, governance models at the state and local levels, and data collection measures. I think smartly, the commission is led by former health officials. It's bipartisan, it's both sides of the aisle. It's not meant, there are no sort of preconceived notions here. Here, the idea is how do you strengthen the public health system? How do we make sure there's an understanding of public health laws, governance, and how do we better prepare to tackle future public health challenges? And also part of this is also communicating to the public the role of public health and its statutory responsibilities to public health and the important local and state role there is. And so there are a number of sub-actions, both for elected officials and health officials in this area. Next slide, please. In terms of partnerships, the task force really came down on two critical actions. One is to incentivize partnerships between public health departments and other sectors and stakeholders. The business community came up quite a bit. We have done work in the past about the value proposition between business and governmental public health, particularly with respect to improving community health and the important alignment there. Here we provide an example. One of our task force members led this, where the Kansas City, Missouri Health Department linked up with the Kansas City Chamber of Commerce to move forward important policies to restrict tobacco sales to youth under 21. And there are many examples like this. But there are opportunities, there are many opportunities out there. You can imagine every local public health department in this country probably ought to be collaborating with their local chamber of commerce on some important public health issue. And so I think that's just one example, sort of the business public health opportunity there. There are also opportunities with faith-based organizations, healthcare organizations as well, other sectors. There was a second action articulated by the task force focused on state and local jurisdictions dedicating a body charged with routinely monitoring, assessing, and influencing the implications for health in all government sector policy discussions. We've talked a lot about health in all policy over the last decade. Now is the time to finally implement this. So really all sectors understand the implications of health impact assessments we've talked about for a long time as well, understanding how the policy decisions of other sectors have health implications as well. So health in all policies, bodies, commissions, health impact assessments in terms of legislation, all critical tools to be used at the state and local level. And final slide, please. The final area focuses on again, community engagement. It's not what we do for communities, it's what we do with them. The task force felt strongly that we need to invest in the capacity of community-based organizations, invest in long-term relationship building and partnership development with residents and community-based organizations. The example here is from the de Beaumont Foundation program that you may have heard of called Phrases, which is really, I think, an important way where public health can articulate to community-based organizations and communities what it is that public health does and why partnerships are so important. But really investing in the capacity of community-based organizations is something that some in public health do, but it is not really across the board something that everyone does. And that was an important point that the task force wanted to highlight. Final slide. And so that's just really a run through of the 6 areas, the framework that is essential to achieve the vision that the task force articulated. In terms of next steps for state and local policymakers, once we release this report tomorrow, I think, and this is something all of these steps are things that you all are already doing. But I think it's really important to take advantage of the moment. There is significant funding coming from the federal government. We've seen it through the COVID relief packages. We've seen it through the American Rescue Plan. Even the bipartisan infrastructure package recently passed has elements that support health. And so understanding how to leverage the resources coming to states and localities, even if they're not coming directly to the public health department, I think are critical. That's a part of tomorrow's report. Prioritizing some of the public health forward recommendations that are most appropriate for your localities, for your state. You'll read some of these recommendations and you'll say, we're already doing this. We've been doing this. Others you'll say, we need to do more of this. And again, so it's tailoring exactly where you are, your state, your localities. So I think reviewing the recommendations and again, even though there are 12 top line actions, there are many different strategies and sub-actions that are articulated in tomorrow's report that hopefully will be beneficial. And then finally, it's really consulting. It's elected officials and health officials. It's got to be both. It can't just be public health. I think one of the themes of the report is the leadership role of elected officials to support public health officials, and then consulting with non-governmental organizations who are critical partners to ensuring, again, that all of these actions are supported and implemented so we can reach the vision. So I think that there are some concrete next steps, many of which that you all are already doing in New Jersey. But Jeanne, maybe I will end there and hope that this was a helpful preview of what will be coming out tomorrow. And again, we invite all of you to participate tomorrow and looking forward to continuing the dialogue with all of you.
Thank you so much. And how lucky are we to get the sneak peek? It's like amazing. So I guess what I'm just kind of wondering, I'll ask the first question, then there's a couple in the chat that I would bring up, is what is it that you think the coalition that you're leading will do next in terms of outreach and working with policymakers?
Yeah, it's a great question. So we have teamed up with a number of entities. Again, I think elected officials are critical. So the National Governors Association, the National Conference on State Legislators, the National League of Cities, the National Association of County Officials. If we really want this to come alive, we really need their support. Again, it can't just be about public health. A lot of this public health knows. I think it's got to be broader than that. And so I think part of it is really going to be educating elected officials at the state and local level. I think that's part of it. I think some of this also, is necessary to help remind the public what public health is all about. Public health is not just about, telling you what to do or COVID mandates. Public health is much broader. And I think the public needs to understand the responsibilities, statutory responsibilities, particularly at the local and state level that public health has to combat not just COVID-19, but diabetes and obesity, mental health and substance abuse and the opioid epidemic, climate change and environmental health. And so I think it's an opportunity to really get the word out, inform the public, inform policymakers. Certainly a lot needs to happen at the federal level, but here the focus was really at the state and local level.
There's a number of items in the chat that sort of reflect on sometimes, at least in our state, the confusion between public health and health care, and then also sort of leading into the responsibilities of the healthcare system, particularly hospitals, to advance these concepts of modernizing public health. I'm wondering if those conversations came up as part of your coalition.
They did, and I think some of the survey data that you just presented reflected that some in the public still don't understand the role of public health or think that it's a segment of healthcare or it's healthcare or health insurance for the poor or the underserved. And so and then others may think public health is, again, just about responding to infectious disease outbreaks, and it's critically important with respect to COVID. But again, I think there's an opportunity there to better articulate what public health is all about. And then Jeanne, just remind me of the second part of the question.
Well, what role do healthcare systems and hospitals play?
Yeah, and so I think, critically here, I think, the low-hanging fruit here is for the vast majority of nonprofit hospitals in this country who are mandated every 3 years to do community health needs assessments and to do community implementation plans. If they're not doing this, with public health, which also needs to do community health assessments, then things are not working correctly. Every hospital, for example, needs to be partnering with their local public health department, their state public health department, to do these needs assessments, and then most importantly, to implement these community implementation plans. So I think that's one opportunity. And then, we had the AMA, we had AHIP, others represented on their task force. And I think every part of the healthcare sector has a role here. And as healthcare continues to transform to value-based healthcare transformation, where you're trying to prevent and avoid things that ought not to occur and to reduce preventable healthcare costs, again, public health is a critical partner there. So I think there will be some specific action items here for healthcare entities, whether you're a payer, whether you're a hospital, whether you're a healthcare professional. But we've been talking about public health, healthcare connectivity for a long time. I think it needs to be accelerated.
So my last question is, having had the opportunity to, be involved in the project here in New Jersey and engage with local public health and our project working group, I can imagine that it's easy for local public health leaders to be frustrated because they feel very much that they've been leading new responsibilities, new mandates without recognition and certainly without sufficient capacity. I guess I'm just wondering whether you leave your work with a sense of optimism that perhaps we could pass along to our local public health leaders.
Well, I mean, I share their frustration, and I don't think that there's any report that will reduce that amount of frustration. Ultimately, we need action. We need action at really all levels. We need action by leaders beyond sort of public health leaders who really know much of this already. And I think that's why our attention and focus is really on elected officials. It's really on the complementary sectors and leaders there that need to support public health. It's taking advantage of the moment. We're in a crisis, but here's an opportunity to ensure the nation and policymakers are educated about public health. They understand the important role. So I share their frustration. I'm sure there's nothing that I can say that can reduce it. But yeah, no, we are trying, however we can be helpful at the Bipartisan Policy Center. And I can only say that, we hear the frustration and we hope that we can try to do something about it.
Thank you so much for joining us today. I'm sure you'll see a lot of New Jersey folks on your session tomorrow, and good luck with the release of your report. As soon as it's out, we will send it to everyone who's participated in our webinar today.
Thanks so much, Jeanne, and thanks to all of you for your leadership. Great to be with you today.
Thank you. Bye-bye. Okay, everyone. So here's our next steps for today. I am so happy to invite Georgia Heise, who's the district director for the Three Rivers Health Department in Kentucky, and Jaime Bodden, who's the managing director of the Washington State Association of Local Public Health Officials, to join us and turn on their camera and come off mute. We wanted to be able to invite two other states' leaders to join us today to talk about some of their experiences in recognizing challenges associated with public health capacity and building coalitions to address it. So again, hoping that some of the stories in other states will invigorate a conversation here in New Jersey, help to support everyone, and leave us with a good sense of optimism. Georgia and Jaime, can you come on? And what we're going to do is ask each of them to just talk for about 10 minutes or so about some of their experiences. So let's see.
All right. Well, this is Georgia from Kentucky. I'm going to assert age before beauty. So I have to put this out there in the very beginning. I'm a registered independent, and I have been my entire life. And so I'm going to talk equally bad about red and blue, because it comes into play in a huge way in everything that happened with our process in Kentucky. And I will have to say that it began way back with when the Institute, it was the Institute of Medicine now, I think, or then, now I think it's National Academy of Medicine, but they did the report that started everything on you should have a minimum package of public health services across the country. And from that, our SHO in Kentucky, which is called CADA, Kentucky Health Department Directors Association. So we started a strategic plan, and at that particular time, we were dealing with the loss of Medicaid funding to the health departments and looking for a way to get funded and a plan that we could present to legislators and that kind of thing. So that's how we got going. And we came up with, what do we really need to be doing? We came up with a way to have a cost for it, and we worked on it and refined it. And meanwhile, what really got the attention of our legislators was the retirement system in Kentucky crashed and had to be invigorated, I guess, and they were looking for a way to come up with money for that, and the health departments are a huge part of that. So that's how we got our little group together. So I don't recommend having that go on, but you could use COVID as your crisis for, something has to be done. But anyway, the health departments could cry forever and we got no one's attention until the retirement thing. And then we did get a group of legislators who, it was Republican led, thank goodness, because fast forward to now, if it hadn't have been, it would have been dismantled probably in Kentucky, but it was Republican led. We had also a sympathetic commissioner at the state level who knew nothing about public health, brand new, 29 years old. But he was willing to listen, and very smart, willing to listen. And he wanted to put his stamp on Kentucky for the short period of time he was going to be in that spot. We all knew he was going to move on to something else, but he was very helpful and politically connected with high level leadership in our legislature. So he helped get this group going, and we had state public health people, local public health people, Republican and Democrat legislators coming together, mostly our Health and Welfare Committee members coming together to talk about what legislation about how public health should be funded should look like. And we had already put together for the group existing funding that could be cobbled together and funneled, that health departments could use it, and it would be designated. There wouldn't be a danger that somebody else that needed the funding could jump in there and move it for something else, which is notorious happening. Pots of money that the health department hopes they get, somebody else can swoop in and take it away. So we were trying to get rid of that. We also have a designated tax in all of our counties for our public health. And what we sought to do there was the minimum level. If you have a high tax base and that minimum level of funding covered your needs for providing your foundational services for your service area, then you did not get, or you got less of certain state funding, and other health departments whose tax base could not cover the cost of the basic services then would get more. That was quite controversial. We had to duke it out in private with our SACHO a lot before we ever got to a place that we agreed on. But, looming in the background was, there's going to be nothing for anybody if we let our whole system crash. So you're going to have to get on board whether you like it or not. And I hate to say it that way, but kind of in some instances, that's what happened. If stuff was working for people, they didn't want to change it. So it was, those of us who were, about to starve or get put out the door that needed to make a change and push it forward and help everybody see what would be the best for our system statewide. But that we had some contentious conversations, I'll have to say, getting to where we needed to be. But we have a group that's really together now on board with where we need to go. It took a while, but it worked really well. And that legislation went through, it passed in 2020. Fabulous. Okay, COVID hit. We have a 2-year budget in Kentucky. We did not get budget language to designate the funding to match the bill of how that the health departments get funding. So we're still working on that. We're getting ready to roll into a budget session this time. So we're starting the same process with the legislators to talk about that. Meanwhile, though, we did hire we raised our CATA dues. We hired a full-time executive director who makes a decent salary and is an attorney and a lobbyist herself, and she's really good. And we also hired a well-known, very successful lobbying firm in Kentucky. So we are well connected now. And that is something we should have done long ago. I mean, I highly recommend it because it gets your issue in the door in front of the people that need to see it. Now, so I'm glad that our bill and everything, our movement was Republican led, because COVID, oh my gosh, caused, our legislature in Kentucky to act the worst. And, we have crazy bills out there about dismantling health departments, dismantling any kind of vaccine requirement, just on and on and on, just craziness. So I'm, very hopeful that none of that stuff goes through. But we also had the same as across the country, all the media hype about a government overreach, wearing the mask, and just on and on. So now I think everybody and their brother feels very, very comfortable in dismissing the government, dismissing science, or calling into question anything that might have been a recommendation by public health and that kind of thing. So the fact that we can remind, our red sector that they, in fact, their names are all over this bill and the support of public health, and now it needs to be funded, is very, very helpful. So maybe that's, you probably get my point. That's my cop maybe could have said it more eloquently, but I'd rather just get to the point with it. But I did have two things that I really want to get out there. One was all the nifty graphics and the nifty slogans and this, that, and the other thing. They're wonderful, but get at least one thing that everybody can agree on and hang your hat on. Because if you get too many of them, nobody knows, well, is it this thing over here or that thing over there? Don't confuse, all the people. Get one thing that's very consistent and hang with that. You can have all kinds of other nifty stuff too, but one thing needs to be on everything you do so people understand this is public health, or whatever. Public health transformation was Kentucky's our tagline. So public health transformation, that's on all of our bills. Everything that we move, it's got that on it. The other thing is you want all the help and all the attention you can get, but be careful in terms of the people that go all over the place and get involved in these other efforts. Make sure they also have the tagline. They can talk about their other stuff too, but don't get too many people doing too many different things and get off the shared vision. Because if you do that, you're divided and conquered. So, keep your message, which is we all need public health. We all need it. It needs funding that is designated. That's the big message. So whatever anybody else is doing, make sure they got that somewhere, because all day long, stuff comes up all over my phone and my computer about this, that, and other thing that's happening. And, nobody can do everything. So there's lots of different people involved. Just make sure that people that are going and speaking on behalf of what you're doing can refer people to someplace where the real accurate information is, so you don't get things muddied up, I guess.
Georgia, thank you so much. There is one specific question in the chat about whether your congressional delegation, particularly Senator Mitch McConnell, participated at all in advancing your success.
I doubt it.
Okay.
If he did, I don't know about it.
Okay. So let me invite Jaime to come off camera and talk to us a little bit about her experiences. Jaime, you there?
I am here. Good morning.
Hi.
Good morning, everyone. And first, I'm a SHO, and so it's my duty to first thank you all for all of the work that you are doing every single day. You guys do not hear it enough, and I just want to express my gratitude. And even though you are in New Jersey and Georgia, you're in Kentucky, thank you. I have such gratitude and respect, and it is an honor to get to work with you all and work on behalf of you all. So thank you first. So foundational public health services in Washington State. We are approaching year 10 of our effort. So this is a decades-long effort in our state, and it has been a slow and steady kind of process for us. We started in 2012 with a kind of a call to action for our state to get public health funding because of the recession that had just happened. Budgets were cut 50%. We were losing staff and workforce in droves. And at the same time, people were moving to Washington, so our population was growing very fast. Diseases were changing. Seattle was becoming more of a global hub than it already has been. And so we just knew that something needed to happen. So we had this call to action in 2012. Slowly over time, we got the ability to do some intense baseline assessments. So really kind of identifying what exactly are we asking for the legislature to fund. So we have a core set of definitions for FPHS, Foundational Public Health Services, as well as how are we doing in terms of implementing all of those core definitions and core programs and core services. So we did that in 2018. So 6 years from our call to action, we were able to actually complete that survey and that assessment. And we identified for the public health system, and so that is local health departments or jurisdictions in our state. We call them local health jurisdictions, our state Department of Health, our state Board of Health. And then we also have tribes and our urban Indian health institutes involved in this work as well. So that whole price tag is $450 million a biennium, which seems like a big number, but is probably not a surprise to any of you on this call that, that probably seems appropriate, given that just the nature of the work that we do, the funding over time that has become categorical and stagnant or decreased, and just the need for complex solutions in public health. So 2018, we did the assessment. We went to the legislature in 2019. We operate with biennium budgets in Washington state. So odd number years are our budget years. And so we went to the legislature. They had given us a one-time investment of kind of like, we're buying the idea, but we need to know exactly, what we're buying. So they did that in 2017. 2019, we came back and they said, okay, you've sold us on the idea. We're going to start investing. So we were able to secure ongoing public health funding for our system. It was $20 million of biennium, increased to $28 million of biennium the next year. That is not $450 million. That is a drop in the bucket to what we were asking for, but it was at least a start. And what was encouraging about that is that it was ongoing. So it was not funding that was one time that we'd have to come back budget year after budget year after budget year to try to secure. It was, we're guaranteeing you this money from now on going forward. Additionally, in 2019, we passed a policy bill. And from the local perspective, this policy bill was incredibly important for two things. First, it outlined the foundational public health services framework in which we want to operate as a state system, state and local together. It solidified that in state statute. So it outlined FPHS, gave us the goals in state statute. More importantly, it gave us a concurrence process for funding decisions around foundational public health services. Washington state, we are home rule through and through. We love our local control. And sometimes that's incredibly beneficial. Other times it's not. What concurrence did for us in Washington was that it gave us a seat at the table for funding decisions. So instead of having the state and our Department of Health getting money and then determining, locals, you're going to get, X percent, which never seems to be, particularly transparent in that funding process, or perhaps equitable or fair or whatever. Now through the concurrence process, we are there at the table and we are making that funding decision with the state. We enter into discussion and we say, okay, we have $28 million for the biennium. How are we going to invest that into our system? And we make that decision together, and we make funding distributions decisions together. And that is incredibly powerful. That is very new for us in Washington state, but that has really elevated the local work that we do with local health jurisdictions, really elevated that at the state level. And that is really, really important. And that is something that has been incredibly helpful as we work through COVID. So like I said, this has been a 10-year process, and it's been slow and steady. And we've had some unique things that have helped facilitate this work. Engaging with your legislature early and often is incredibly important, particularly as they are the ones that set the budget. We've been very fortunate in Washington where we have legislative champions who come from local public health. Our current House Speaker works at the Tacoma Pierce County Health Department. And so we recognize that that is not necessarily everybody's situation, but we've been very lucky that we had legislative champions who either come from local public health or were interested enough in the issue to commit to working with us for the long term. And that's not just Democratic legislative champions. We also have a number of Republican legislative champions. And what's great about that is that they will tell us up front, your message isn't working, or we have these questions, you need to be able to answer them. And that's been really helpful in terms of us of honing and refining our asks, honing and refining our messages, and developing a message or a story, if you will, that rings true for a lot of different people and a lot of different backgrounds. And that's really, really important. And so legislative champions, incredibly important. We also pulled in our county elected officials early on. They are also taking this on as a legislative priority, so they advocate for us as well. And so they're part of this larger group advocating for public health infrastructure and public health funding. Our governor is very supportive. Some might say he at times can be too supportive for his own good. He's our newest, epidemiologist expert in our state, for better or worse. And so he's been really supportive. And then we've also engaged, again, over time, a lot of other public health partners. We have a roundtable coalition that includes local health departments, our state Department of Health, tribes, our medical association, our hospital association, a lot of our community-based nonprofits, unions, everybody advocating for public health funding. So this is not just a government advocating for itself, it is us with a lot of community partners really advocating for us. So over time, we've been able to build that success and secure more funding. Then COVID happened. And I really want to pause on that because we had a lot of momentum going. And I've been describing and we've been going through this transformation and modernization before COVID. But COVID has become this evolutionary event for our public health system. We have a lot of resources at our disposal now. We have a lot of eyes and attention, and in some respects, that's amazing and wonderful and great attention. And other times, it's maybe not so great attention. But we have a time in our work that we either evolve and we modernize and we transform, or we don't, and things change really drastically. And so I describe it as, public health system was like a dinosaur, and our meteor hit, and we're either going to evolve and become a chicken, or we're going to become a fossil. And so in 2020, our legislature, recognizing and really early on, and if you'll recall, 2020, COVID hit in Washington first. So we went fast and furious to our legislature getting resources for public health. A lot of COVID response is foundational public health services. So the legislature invested in 2020. They came back this past session earlier this year and invested. So we went from $28 million of biennium. Now we are at $175 million of biennium. So over the year, they saw the work that we were doing and said, we are committed to building public health. We do not want this to happen again to our state. We recognize that you are getting a lot of federal resources, but we know that those federal resources are going to end or are very categorical. So we've been able to use foundational public health services as kind of that launching pad. We are doing the immediate work right now around COVID, but we are also setting up our system and building up our system infrastructure so that we have a handoff in a post-COVID world where we are building new data systems, or we are building diverse staff who are going to be able to be nimble and adaptive to different public health emergencies. We are starting to tackle things like equity and racism and climate change and these really complex issues where they need a facilitator, and public health has been able to enter kind of that space as that convener and facilitator. So that's kind of the situation that's going on right now. I know as you begin this work, my advice for you are a couple of things. Slow and steady. I know it's really hard to think that because everything is so immediate and feels so urgent right now with COVID, but really having slow, steady, deliberate processes, working with consensus as a local group. My state show is diverse. I have King County that serves 30% of my state's population, and I have a handful of counties that serve less than 5,000 people. They are not the same. They do not have the geographic, the demographic, the political views of the same. Almost everything is completely different for those jurisdictions. Yet we work and we are very deliberate in finding levels of comfort and consensus so that King County feels comfortable with decisions that are made that might elevate smaller rural jurisdictions. And likewise, rural jurisdictions are comfortable with us moving forward on things that might benefit our urban metro areas. So we have that dialogue, we have that space so that we can work through those differences, those tensions as a SACHO, find that comfort, find that consensus if you can get there, and then use that as a form of alignment and unity as you move forward with the legislature, as you move forward with the state. That is absolutely critical. If you can be a strong, united front, it only helps you and it only helps the system. And that is something that has taken us a long time to figure out. We are still constantly, I would say we are a teenager in that respect. We have not yet quite fully matured. We act out at times, but it is really, really important. And as you embark on this endeavor, I can't stress that enough.
Jaime, thank you so much. You're getting a lot of shout outs for your dinosaur metaphor. And thanks to both of you. Thank you. And there's a number of items in the chat thanking you for your leadership, your power, your optimism, enthusiasm. I guess I just have one question, if both or each of you want, one of you want to respond to, which is there's also a number of items in the chat about to do the work that you've done, it's definitely involved public health getting into politics. And just, was that a hard step to take, and any other advice you might have on that topic?
Yeah, I'll go first. I think Washington has a reputation of being incredibly liberal and progressive. And sure, 3 counties in Washington state are incredibly liberal and progressive. They happen to be, more than half of our population. But you go to east side of our mountains and you feel like you're in a very different state. And that is incredibly apparent with COVID and how COVID has played out in Washington. For example, and even at the local level, there is a very significant disconnect between political affiliation and political ideology at the local level versus at the state level, and particularly with our governor. And so we're navigating that tension constantly. I think one of the benefits of public health is that you have to. If that's the context that you live and operate in, you don't get to just put on a shield to politicization. That's just your reality. I think one of the benefits of local public health is that you guys get it because you're living it. And I think with COVID, you're probably living it a lot harder than what is fair or right. But you understand it, and because it's your neighbors, it's the people that you see in the grocery stores, it's the people that you're interacting with every day, and that's incredibly helpful. I think it humanizes it a little bit more. I think it helps soften it a little bit more. For public health, for us, for funding, it was all about we know things aren't equal everywhere. There were things happening in King County that weren't happening in Eastern Washington. We're like, well, we want to bring that to Eastern Washington, and vice versa. We know there are things happening in Eastern Washington that are really, really fantastic. We want to bring that to the west side of the state too. And so there is politicization. I think public health for better or worse, we have to engage in it. But I think we also bring, and this is probably more of the social worker in me than the public health professional. So full disclosure there. But I think, we have the skill set and we have the profession where we provide that space for that dialogue to work through it. It's going to be hard. It's going to be really, really difficult, but that's one of the things that public health does, is that we bring people together. We serve people. We're a profession of service, and whether that service is really easy or really hard, for better or worse, that's what we do.
Thanks, Jamie. Georgia, do you want to comment at all on the politics thing?
Well, I have to, because I had a professor long ago in public health who said to me that, well, he said it to a lot of people, but public health is at the nexus of science and politics. And I think that's never been more true than now. Want to stand up and applaud the folks that are willing to try to work with both sides. Our elected officials that do that, and the policymakers, there's very few of them that do that very well. Now it's just easy to dismiss any idea if it's not your party's idea, which is, not going to take us very far. Also, it's disappointing that we have a lot of well-intended policies that get made and then they're pitched over to administrators who maybe to promulgate regulations, who then maybe miss the intent and then nobody ever follows up on it. So I'm always, it's great when we get this stuff about from legislators that these people are going to be required to do this, that, and the other thing, like data collection and turning it in, sharing it, and this and that. But if nobody ever follows up on that, it's not very helpful. And those are just things about politics that maybe places public health can help our policymakers see, that they kind of have to follow it all the way through. You can't just put it out there and then drop it, because it doesn't always work the way you want it to.
Georgia and Jamie, thank you so much for joining us. Please know that just these little bit of time that you've been joining us has led to quite a conversation in our chat, and you've inspired us for moving forward. And congratulations on your amazing work. And thank you so much for joining. Okay, everyone, we're going to enter into our last panel discussion. There's Georgia's cat. So I am happy to turn this over to my colleague, John Gattuso from Gattuso Media Design. John has led the communications and video development work and case story work for this project. And I'm inviting John to put on his camera and his microphone. And then we also have the members of our project working group who will introduce themselves to you for a conversation on what does this all mean? What does this all mean for public health in New Jersey? What I'd like to invite everyone else to do is John will be facilitating a conversation with our project working group. But if folks who are participating want to put questions or comments in the chat, I will be monitoring the chat and I'll add them into the discussion, and then that way we can have this be a conversation with the project working group as well as everyone else on the webinar. So John and everyone else on the panel, you can put on your microphones and your camera, and I'll turn it over to John.
Good morning, everybody. Good to be with you. We were really fortunate this morning to have our project working group with us. And this is a distinguished group of public health leaders and practitioners who together have decades and decades of experience. So what I'd like to do with this conversation is get a feeling for the sort of ground level experience of the issues that Jeanne and Karen have given us a high level summary of. But before we get to that, let's do introductions. Why don't I have the project working group members introduce themselves, and we'll keep your introduction brief, and we'll do this alphabetically, I guess. So why don't we start with Margie and then Kevin McNally. Margie, why don't you go ahead and very briefly introduce yourself?
Sure. Hi, good afternoon. My name is Margie Jeanne. I'm a health officer at Freehold Area Health Department, and I'm here representing the New Jersey Association of County and City Health Officials.
Great. Kevin McNally?
Okay, I think Lynette is actually ahead of me alphabetically, but I'll go in the interest of time.
Okay.
In the spirit of the season, I'm kind of the ghost of Christmas past, a ghost of public health past on this discussion. I am a retired former public health and healthcare worker, more than 40 years in the two fields, including 30 plus years with the New Jersey Department of Health. I'm a past president of the New Jersey Public Health Association and currently the chair of the executive board of the association.
Great, thank you. Lynette, you're up next, followed by Tara.
Okay, hi, I'm Lynette Medeiros. I'm the current president of New Jersey Environmental Health Association. I've been in the field for well over a decade. I'm an REHS and I'm currently an assistant health officer in Hudson County for the city of Hoboken.
Thanks, Tara.
Hi, I'm Tara Rice. I'm a health education consultant, and I am the president-elect of NJPHACE, which is New Jersey Society for Public Health Education.
Great, thank you. Paul and Shireen, you are next. And then lastly is Kevin Sumner. Paul, go right ahead.
Hi, I don't know how to get out of the small box to the big box, but that's okay. My name is Paul Roman. I'm the past and present incoming president of the New Jersey Local Boards of Health Association. Spent 53 years in EMS and 45 years in public health, all volunteer as an educator, administrator, and advocate.
Thanks, Paul. Shireen?
Yeah, hi, everybody. My name is Shireen Semple. I am the director for the Office of Local Public Health at the New Jersey Department of Health. I've been with the New Jersey Department of Health for close to, 19 years now. Started in the department as an epidemiologist, but before that, I had the privilege of working at a local health department in New Jersey. So my trajectory to being the director of the Office of Local Public Health was something that was, I still count as one of the greatest professional achievements in my career because I am one of the biggest fans of our local public health system. Thank you.
Great, thanks. And Kevin Sumner.
Good morning, everyone. Kevin Sumner. I am the health officer for Middlebrook Regional Health Commission, and I facilitate the Public Health Association's collaborative effort, which was formed a long time ago to bring together all the associations you just heard from to work collaboratively toward a vision for public health in New Jersey.
Great, Kevin. Thank you so much. Actually, Kevin, while I've got you talking, why don't I ask you a first question? And then I'll invite everybody to chime in, as you like after Kevin takes a swing at it. So, Kevin, I'm curious. You've been working in public health for, I think it was about 35 years or so. What kind of changes have you seen in public health over the last 20, 30 years? What are the issues that you're dealing with now that you weren't dealing with early in your career? But more than that, how has the practice of public health changed? The approach to public health changed over that time?
I think the simple on the surface answer to that, at least for New Jersey, is that when I started in public health, 36 plus years ago now, I mean, our focus was almost exclusively on environmental health issues. New Jersey had a fairly long history of environmental contamination. So we have those issues to deal with, plus, the traditional environmental health activities of food inspections and, nuisance complaints and those sorts of things. And there was not a whole lot of conversation or discussion about larger issues that are impacting individuals and communities' health. And I think over the years, we've seen a very slow transition towards these larger issues that aren't as tangible, especially to the general public. I think that was reflected in the Eagleton poll results to some degree. We're still seeing some of these, very concrete ideas of what public health is. And yet we've heard throughout the morning about the social determinants of health and our need to collaborate and really involve public health in some of those broader, bigger issues that influence and impact the health of our communities. And while we've started to talk about those changes, and we've seen some movement in that direction. I think we have a long way to go.
Earlier, Jeanne used the phrase chief health strategist to describe the role of public health officers. So I'm wondering, actually, Marguerite, I remember in a previous conversation that you used the same phrase, and I'm wondering if you can just flesh that out a little bit. And I'm particularly interested in your example in Freehold, bringing a federally qualified health center there, and how that illustrates this role of the chief health strategist.
So the chief health strategist is really the role that we've now begun to take on. We start talking about social determinants of health and starting to impact living conditions that ultimately underlie health conditions within our community. We have to look at our community in a much broader picture, and we really need to be a change lead. We really have to be there in the forefront, working with other leaders within the community to bring about change and to move some of the existing the silos that are there and working together. In Freehold, I have been fortunate enough to work alongside a coalition with the hospitals, with local agencies, churches, other community-based organizations, where we have worked collaboratively to find solutions to issues within the borough, and have been very, very successful. And the Federally Qualified Health Center was an idea probably 11 years ago, where it was knocking on the door of the CEO for the local hospital. And 9 years later, it became a dream. And it was really all about collaborating with the community as a whole, not just with. And we need, as the health department, we're kind of that convener or a neutral party, and we should use our position in the community to really help leverage other entities to come together and accomplish what needs to get done.
So the role of public health has changed. You're working more at the level of policy. You're building coalitions. You're collaborating with members of the community. Earlier, we were talking about funding, and I guess the answer to this question is predictable. I'm going to ask it anyway. Are you finding that you've got adequate resources to do the job of public health as it's currently understood and practiced? Anybody can chime in. Paul, maybe you have any thoughts on this?
I'll say no. I'll just come out and say no. Traditionally we've been funded to do environmental health, communicable disease control, nursing services, health education, to get into the community and interact with the community and help influence the community, and to bring the community to lead themselves to where they need to go. Takes more manpower, better skill set with the existing positions that we have. Not that those positions are not healthy, but I think that we need to invest in a different type of skill set to really help us connect to the community and help bring about those changes. And the current pay structure, and I don't mean pay as in salary, but the current mode of monies that we get only allow us to do this limited, right?
And is it just a question about the amount of money, or is it how that money comes to you? What you can do with the money in particular?
John, before somebody answers that question, I want to be a little bit, maybe even stronger than Margie. Your question about, do we have the funding to do the new activities, the newer activities, this changing role of public health? I would go so far as to say, I'm not, with the degradation of funding that we have seen and resources and personnel, qualified people to do the work that we have seen over the past decade or longer, I'm not even convinced that we have the resources necessary to do those older, more traditional activities of public health in New Jersey, much less the newer activities and responsibilities around the changes in public health or responding to emergencies and pandemics.
I would completely agree with Kevin as well. I mean, we definitely have major funding issues, and it's causing an issue with having continuity in staff. We don't even have a lot of the basic support staff that we need every day. And this is dwindling as people retire. And a lot of our members are starting to go private industry because they don't want to deal with the political sides and the lack of funding. A lot of inspectors are making very little money, and you know that you can go into private industry and make a lot more money, unfortunately. And this is something that New Jersey needs to improve on. We are highly educated. It takes a long time to get where you are. We have to learn so much in vast areas. We definitely need more consistent funding. And that funding needs to funnel down to the local levels where we can actually spend it, where it's not earmarked towards very special, things or very, we need to be able to use it on a local level and be able to enforce public health.
Fill that out a little bit more, Lynette. So you're saying a lot of these funds are earmarked. What are the constraints on the spending that you can do in terms of restricted funds?
So a lot of money that comes down the pike tends to be in the form of grants. And while grants are great, there's usually a lot of very specific stipulations how you can use those grants and implement them. And most of that is temporary funding. New Jersey, Jeanne had talked about it before, that we used to have public health priority funding, and that at least was somewhat consistent. It certainly wasn't enough what we were all receiving, but at least that trickled down the local level where you were able to apply that to different areas. When you are really under the auspice of a grant, it really dictates where you can spend that. And a lot of time, even with grant monies, the health departments aren't always the decision makers where that money is necessarily being spent. A lot of times, unfortunately, you have policymakers and politicians that are making those decisions for us. So we really need consistent funding. And you can ask any one of the public health organizations, and what would we all say? We need consistent money that is not earmarked, that we can really put, because where I work in the state, I'm in a completely urban area. Kevin covers a whole different area. Margie covers. We are so diverse in the state of New Jersey. Every health department, the way we're structured, we're all composed differently. So when you know your home base, you know where the money needs to be applied. But my number one thing is to increase our working force. And that's both health officers, our EHSs, our health educators, public health nurses. We need to grow our workforce, and we need to make sure that they're adequately trained and paid.
Okay, so I'm hearing there's not only issues with quantity of funds, but with the sustainability of funds and the flexibility on as to what those funds can be spent on. So as a member of the public, as a taxpayer, I got to ask, what's not getting done when there aren't adequate resources? What kind of constraints are you facing when you haven't got the resources to do the job that needs to be done?
John?
Yeah.
John, speaking on behalf of the boards for our local health departments, when public health priority funding, which now equates to $11.2 million that we lost in New Jersey, for all that time from 2011 until COVID, health departments were constricting, losing paid staff, unable to do programs, having to make decisions as to what of the mandated services are going to be fully taken care of. So the public wasn't served at all by this loss of funding because the state had a financial problem. And the fact is that there are still some things that are very, very funding related, although this shouldn't just be a plea for money. But unfortunately, that in New Jersey, as you saw the numbers as we worked through all of this, and you heard from our partners around the country, is the root of all evil in this situation. Money, as I said in Jerry Maguire, follow the money. All the reports point to this. The survey that Eagleton did, comes up with the same answers that in August and earlier this year that Yale and Harvard did surveys around their states and found the same results, that the public just doesn't get it. And local officials, because of the constraints of cap in New Jersey, 2% cap, are not able to put more money into it, nor do they really see the need for it.
Great, thank you. Okay, I'm going to move things along a little bit. You made a clear case on funding. Let's turn to organization. There's often kind of I don't know, it's almost like a knee-jerk response when this topic comes up, which is consolidate or do the opposite, break agencies up into smaller units. And my understanding is that New Jersey has a somewhat unusual organizational structure compared to other states. Kevin McNally, I'm wondering if you can address this. Can you just give us like a quick, very thumbnail sketch of New Jersey's organizational structure in regard to public health?
That's the biggest problem, John, is that it's impossible to give a thumbnail structure of New Jersey's public health infrastructure because it is so varied. And I would argue that, and I've had this argument with many of my colleagues on the phone, that we do not have a public health system in New Jersey. I was the author of the 2008 study that Jeanne cited in her discussion when we looked at the structure of public health in New Jersey. You have to understand how we're based and where it came from. New Jersey's public health structure is classically New Jersey, i.e. it is home rule, it is municipally based, and it is based on a law that was passed in 1880, which gave public health responsibilities to each municipality and required them all to have local boards of health, which, as my colleague Paul knows, they don't always know that they're supposed to have one, and they don't. So we've had this municipal-based system now for 140 years, and we've added over, as issues came up with that over time, we've added other layers to it. Regional health commissions in the late 1930s, local county health departments starting in 1960, but not all county health departments at the same time. Each county decided whether or not it's going to have a health department or not. So they tend to cluster in what used to be the rural areas of New Jersey, the northwest and the south, where the municipalities were too small to really provide adequate services. We then gave the counties additional environmental health responsibilities, the County Environmental Health Act in the mid-1970s. And then after 9/11, we gave the counties additional preparedness responsibilities as links agencies. But all these have been patches on a basic system that exists since the 1880s that hasn't really changed. The other issue with public health in New Jersey is that the structure is fluid. As Jeanne pointed out in that chart she showed briefly, most municipalities in New Jersey participate in some kind of shared services system for New Jersey. But those shared services agreements are basically year-to-year agreements. They have terms, but they're year-to-year agreements between individual municipalities. So if a municipality thinks it can get a better deal from another health department, it can close its health department and contract with the other health department, and 2 years later decide to contract with another health department. So we've seen this change over time. And when I worked in Shireen's office at the state, we used to have to revise the directory of local health departments every month because there were so many changes in the structure. The pros of New Jersey's structure as it exists is that it tends to be responsive to local needs and has good connection to the locals. The challenge is that explaining it to the public. If the person from the public says, well, who's my county? Who is my health department? Who takes care of my town? I can't say it's your town. I can't say it's your county. I have to say, well, you have to go to the state health department's website to look up your town to see which health department covers you. Because depending on what arrangement your town has, it could be your town, it could be the county, it could be the next municipality over, it could be a municipality on the far side of your county. It's really driven by municipal decisions, which are made primarily for financial reasons. Where they can get the minimum services for the lowest dollar.
It's confusing, no question about it.
Absolutely.
But are the problems that public health is facing now, I mean, would you say that they are principally organizational in nature, largely organizational in nature?
Well, there are organizational problems because of this, as Kevin so well explained just now, the dichotomy of the various types of health departments and how they're formed and why they're formed. there's 565 municipalities in New Jersey, as we all know, and there are exceptions. First of all, everybody's supposed to have a board of health for governance, for oversight, for policy decisions. But because of things like Faulkner and Walsh and other governmental structure aberrations in New Jersey, there are approximately only 450 boards. And the fact is that because there's that limit to the oversight, there's less people to actually enforce the governance and policy and funding and everything else that goes on. And consolidations, hell, New Jersey's been the shared service leader in this country. Years and years and years ago, there were 400 health departments in New Jersey. Right now, we have 104, and they vary from local departments that are on their own, local departments with contracts to other towns, regional health commissions that were formed in 1938 by an act of the legislature, and county health departments, as Kevin explained, that were formed through the CHA Act as a response to the CHA Act.
Okay, so John,
yes, go ahead.
I can't hold it in anymore. Sorry. So Jeanne talked early on in her presentation about the review of a 30-year history of New Jersey's public health system and the various reports, and almost everyone, maybe every one of them, I don't recall, spoke about the structure of public health. And yet we've seen this slow evolution of public health in New Jersey over that time period, and an improvement, I believe, in the services rendered by the public health system in New Jersey. Certainly, we have, with practice standards, adopted early adopters of the Public Health Accreditation Board concept in New Jersey. Really, at the same time, accreditation was being talked about at the national level. And we've seen that New Jersey is on par, if not, it excels compared to other public health systems across the country. Jeanne talked about the density of population in New Jersey as compared to the other 8 states that they looked at, and how, even when comparing to states that we think of as very populous, like New York and Connecticut, we are significantly more densely populated than even those states. And yet we still talk about how many health departments we have to service all these people, not to mention the diversity of those populations. We've talked about this for so long. It's not, I was trying to think earlier who made this comment about something. It's not the blank stupid. I don't remember what politician said that. It's not the structure, right? It's the resources. If we had the resources, we wouldn't have this inherent competition amongst communities to seek the bottom line. If we had the value perspective of public health in this state, where it was perceived as a benefit to our communities, we wouldn't have these conversations about low dollars and resources. It would be supported, and we would certainly not have the conversation around structure. So, sorry to get on the soapbox, but we spend so much time talking about structure that it diverts us away from the real issues, which is the resources, and more importantly, the people that are doing the work of public health in this state that aren't valued and respected, and across the country who are losing their jobs. And we need to change that conversation if we're going to change the perception and the direction of the public health system in New Jersey.
Great. Thank you,
John, go ahead, Kevin. I'll ask the question after you go.
Respecting everything that Kevin just said, the structure does very much impact on the availability of resources, because the fact that the core responsibility resides with the municipality or with the county, if the municipalities have punted to the county, means the responsibility for providing those resources falls largely on the local level, where it has to compete with other essential services like police and fire and schools and roads. And looking at a comment we had earlier about reallocation of resources, that's the challenge that locals have faced all along, is having to compete with all those other essential services for the limited dollars available at the municipal level when people don't want to pay more property taxes. And all of those other services, essential services, are more visible to the public on a day-to-day basis and have their constituencies very stronger that public health often lacks. So the structure has allowed the state basically to evade its, I'm talking about politicians, not the department now, the state to evade its responsibility to assure that the locals have the resources to provide the core services.
And I'll just add to Kevin's comment, based on the one study we had looked at, I think it was 2009, that, indicated, and it was from the State Department of Health, that, an overwhelming majority of resources for local health departments came from property taxes. And I do want to come back to the question that Kevin McNally pointed out is in the chat, because it's in a couple different places, which is, have local health agencies had any success in being able to work with their colleagues in other departments and offices and agencies to reallocate funds, whether it's for County Environmental Health Act work or for transportation or other things, to be able to fund core public health services that have a relationship to that other sector? My guess is the answer is no, but
it's no. With the partnerships exist within health departments as required, and especially for accreditation purposes, but more importantly, because it's the right thing to do. But there's no money out there coming to public health from the partners. They're all striving to get money themselves.
And we have some excellent models of cooperation in New Jersey, excellent models of partnership, of really implementing Public Health 3.0. And a couple of people on this panel right now are part of that. Margie and Freehold, that was mentioned, Kevin and Baumberg. But those partnerships exist not because they're locally funded or health department funded. Those partnerships exist because of grant funding, because of philanthropy funding, because of the Robert Johnson Foundation and the New Jersey Health Initiatives funded those projects. But implementing the real community-based public health that's envisioned by 3.0 is one of those areas for which there is no resources, because there's enough resources even for the core functions, as Kevin mentioned.
There's a question that's related to that too, as to whether there's an experience in public health agencies, state and local here in New Jersey, that sees that increased funding for COVID whether that has reduced other types of public health funding.
I don't think we've seen that yet. I think it's just been additional funding that's come our way. So that's not affected the other services per se.
But just a warning for the future, because again, that's very specific. We have the example of the public health emergency preparedness funding that came in after the tragedy of September 11th, 2001. And that funded a lot of services and a lot of people and a lot of work on preparedness at both the state and the local level. But what happened was that money came in 2002 in the middle of a state budget crisis. So what happened at the state level is a lot of people who were on state funding got laid off on June 30th and then rehired on July 1st under public health emergency preparedness funding. And when those people then left the department or retired many years later, including yours truly, they were not replaced. I was not replaced. 8 years since I've retired, my position was never refilled. And so this department, as time, all the people who not only did preparedness work, but largely part of the infrastructure department, as they've gone on and retired, most of them have not been replaced. And that's probably true at the local level as well.
To show you, John.
Yes, go ahead.
To show you how unlevel the playing field is, county health departments, which national studies have shown are the least cost efficient way to run a health department, where regionals come up the best. County health departments in New Jersey by statute get a special tax on real estate sales. That's the first thing. They're the only ones that get this. The other departments do not get it. The grants that came out, the federal grants, regional health commissions are not eligible to get the rescue funds in the latest federal pump because they're not local government, although they are an association of local governments. I wrote to the federal government about this, got an answer from one of our senators saying that they agreed, but nothing's going to be done about it initially. The other problem is that in a couple of the Senate bills, we're pushing for a change to S1416, where local boards may be the local governing body if it's under 30,000 population because of lack of volunteers. We're asking them to amend that to add mandatory training and education for board members, because it's something that board members who have a responsibility, whether they're local elected officials or whether they're appointed officials, need to have. We're also asking for Senate Bill S1, Sweeney's bill for consolidation of agencies, to delete the repeal of the protections for our public health workers. If agencies are consolidated under that bill, these people would lose their protections that have been there since 1976 for their jobs and their benefits.
Thank you, Paul. There's some interesting questions. Oh, go ahead, Margie.
Yeah, that's okay. You want to go into another question? I can say something at the end. I think I just wanted to kind of go back a little bit to both Kevin and Kevin's comments. Kevin Sumner talking about the concern and about it's not the structure. It's not the structure of the department. And then, acknowledging Kevin's McNally's observation, saying that the structure is what's caused for this issues with funding. And I think, when we talk about public health 3.0, when we talk about working on social determinants of health and trying to impact your community and to be a public health strategist in the community, larger is not going to be better. And I think, in New Jersey, in the 30 years that I've been here, plus 30 years, I guess I should be honest with everybody, we kind of meld to where it works. And we have a great public health team in the state of New Jersey. I think we all do a lot of really good things. And to focus on structure, especially for those that are outside the public health world, right? So there are those that look at us and say, well, this doesn't make any sense. And I'm not saying we have a normal sounding system. It works, it's very effective. And I think it's really important with this study, which you guys have done a great job in presentation and really enjoyed participating in this 6-month project. Maybe this is a way for us to look forward and say, where do we find additional funds outside the local taxpayer, right? Outside the property tax? How do we find additional funds to get us better funded across the state, regardless of what the structure is?
Great. Well, that makes a good segue. There are interesting comments coming up on the chat. It had to do with whether the public understands the value proposition, involved with public health. I was really surprised at the results that Eagleton got on whether New Jerseyans feel that they understand what public health is. And I think the number was something like well over 45%. But in any case, my question to you all is, certainly in order to garner support from the public, from taxpayers, it's important for them to understand the value that public health delivers. Do you feel that public health is well understood at all by the public at large?
John, to answer Senator Conway's chat just now, he wanted the bill numbers. It's S1 and S1416. Assemblyman Conway, sorry, Chairman.
Thank you. So go right ahead. What kind of misconceptions are you encountering in regard to what public health is and what you do?
I think there's a lot of misconceptions out there, and we've seen a lot of them during COVID. You see a lot of the signs that say healthcare heroes. Very rarely do you see a sign that says public health heroes. I think when people think of public health, they automatically see doctor, nurse, medical professional, and they don't realize that there's this whole workforce of public health individuals that are out there conducting infection control and making sure that their communities are safe and trying to implement procedures as early as possible to intervene. And my organization during this, we had done a campaign where we had sent signs to all of the health departments to post "Thank you, public health workers," just to try to get the message out there that, hey, we're working. And the public health force, we are extremely resilient. We're used to band-aiding everything, where we know we don't have the workforce. but we know that we have a task to do, and we somehow, with lack of resources and funding, figure out how to do that task, which is a good thing and a bad thing, because when people don't see failure in a sense, they don't need to correct it because we're making sure the job gets done regardless. I think if we could get the message out there about what public health really does, and it's not just that you're restaurant inspectors. You know, if you talk to most people and you say, what does the health department do? They associate with us with like restaurant inspections and sanitary code. They don't understand all the aspects that we cover. And I think even from a political standpoint, the one thing that we need to be able to get out to our legislators is that because public health is literally in every single thing we do, including the air you breathe, that when you have an effective public health system, you save money. You can do injury prevention. You can diminish gun violence. Your prison systems may be less. It affects your criminal justice system because public health is literally in everything. When you have a good infrastructure and you get the funding and you have great support staff and you bring public health to the table, we really can have an impact on society, not just in New Jersey, but nationally.
And just to respond to Lynette's point, I think there's a couple of things in the chat about how the poll results, pointed very much to individuals as having the greatest responsibility in terms of their health. And so in the chat, there's a conversation about, how do we build capacity in public health when, residents are viewing individuals as the ones most responsible.
We're in a peculiar time right now where not only is it difficult to get the public to gain more of an understanding of public health, but there's also a torrent of misinformation out there. So, you're really swimming against the stream in order to get accurate information out there. Tara, this is a question for you as a educator. What can we do by way of education to counter that sort of misinformation, but also to inform the public about how best to take advantage of what public health has to offer?
Yeah, well, I found it very telling, the Eagleton survey, where it said where people are going to get their public health information. And friends and family and social media were ranked very highly. So I think it was over 55% said they were very likely to get public health information from friends, family, or social media. And, we know social media is a key source of misinformation. And the interesting thing about that stat is that, people aren't going on social media looking for public health information. They're on social media, for 4+ hours a day. They're receiving public health information. Yeah. So that stat is probably much higher, but people aren't actively aware that they're receiving public health information. Right. So, combating it is really, really difficult because it's so easy to spread. It just takes a share, click, and then it's, being spread. But I think first we need to combat it. First, we need to understand what the misinformation is. So we need to get savvier about, doing social listening and understanding what those myths are, misconceptions earlier, because once it's spread, it's too late. You're just trying to sort of, swim against the current. So really getting, using better technology, machine learning, which takes money and time, back to resourcing, but really getting savvier about finding what these misconceptions are earlier, and then making sure we're crafting the right messages to combat them. We're living in a world where we're bombarded by messages. And so, people, they're not going to read a full article. They're reading the headline. So how are we crafting messages? We as public health people, we want to be thorough. We want to use a lot of data, but we know that's not really what sways people. It's stories. How can we use personal stories to engage people emotionally and then support it with data? So just really trying to make sure we're succinct. And I think Georgia said it, clear messaging. Because you only get a few seconds to hook someone and get them to engage. And then lastly, I would say really using trusted sources to deliver the messages. So how do we use local community members, or people that we know the message will resonate more coming from different individuals that are already trusted members of the community. But it's really a challenge, and it's something that I think the research is burgeoning. We're going to learn a lot more about the best methods, but it's really been a huge challenge for us.
Yeah. The other field I work in at Rutgers is climate change. And so certainly that field has had its issues with misinformation as well. So there's a good conversation to be had between public health folks and climate change folks. Okay, good. I've got my eye on the clock. I'm sorry.
One more question, John, maybe one more question.
Yeah.
Okay.
I was just gonna, John, tag on to Tara's comments if I can have a second to do that. I think there are two inherent problems that, one of which we've mentioned, one maybe we haven't mentioned with public health and our perceived value and roles and responsibilities. One, we're in the business of prevention, which makes us invisible. Right. If we're doing our job correctly, nobody sees it because nothing happens. And even with COVID response, what people are seeing, while it's, public health that's doing a lot of the work, it's still being perceived as healthcare. It's giving vaccinations. It's treating people who are sick. Those are the conversations around health that really transition to public health. And I think the other inherent problem is it's population-based, not individual-based. We've certainly seen that in the polling numbers. We've seen it in the divide that has occurred with, individual rights across the country in public health and other issues. We've seen it impact public health professionals and losing their positions and making decisions that impact individuals' activities. But that population approach also means that it takes time, and we don't see the results like we would with an individual approach immediately. And people get impatient. And particularly with the elective process that we have, where people are, promoting activities during an election cycle, if there's nothing that they can hang their hat on because we haven't seen results in public health in a short period of time, then it disappears again. And I think, somehow we have to address those two really basic inherent issues associated with public health before we start to see a change in the way people perceive us. Great.
I can't close this conversation without asking one more question. And then I think Jeanne had a question after that. So let me throw this out to you. We've mostly been talking about, problems in public health. I'd like to know what works in public health. What are the kind of successes you're seeing, strengths that you're seeing that we can build on and expand on in the future? Actually, Shireen, I don't think we've heard from you. Maybe that's something that you'd like to take a swing at.
Thanks. Yeah, so I've been largely silent because I think a lot of my colleagues here are on the front line and are the advocates that we need to hear from on these topics. But certainly, I think there are in New Jersey a lot of strengths that we have in public health. I'll just, as one of them, as an example, our licensed health officer system in New Jersey. We are one of the only states with licensed health officers. And this is an incredibly valuable position and role. As we discussed earlier, health officers are the chief strategist for their agency, for their jurisdiction. They have an incredible amount of responsibility, and they come into their positions bringing a lot of experience, a lot of education. They have to pass a rigorous exam and process. They have to maintain their license through continuing education. It's kind of like when we go to see a clinician. We wouldn't go to see an unlicensed, hopefully, doctor or nurse practitioner, and we wouldn't, go to see somebody that isn't allowed to practice in their profession. And I think in New Jersey, having licensed health officers allows us to accomplish the two things I've heard a lot today. It allows us to maintain this diverse local health infrastructure that really benefits our diverse population and the different landscape that we have in New Jersey with our demographics and our needs. And yet it also allows us to maintain, again, a very rigorous standard and allows us to achieve that I don't want to say minimum because again, our health officers exceed that, but it allows us to be diverse while still maintaining that standardization, that process among all of our licensed health officers. And so I just want to point that out as one of the benefits to our system, and also our health officers being the advocates that they are, and continuing to fight for increased funding, discretionary funding, sustained funding, while still being able to serve the populations they serve, whether it be a regional health commission, a county health department, a municipal health department, shared services agreements. I think everyone has raised excellent points, and this all comes from the crux of that position. So I find that to be one of the big strengths of New Jersey, and hope that everyone continues to maintain that statutory authority, that regulatory authority, and support for our health officers. Thank you.
Thanks, Shireen. And you're getting a lot of shout outs for your comments in the chat. So thank you.
John,
go ahead, Paul.
I can just make one comment. Population health, someone made the comment that population health might be the proper term to insert so that people better understand that we're representing community and not just public. The term population health is being used around the country. And finally, I'd like to echo a comment that Dr. Eddie Bresnitz put out in the beginning of the pandemic, and it's been reflected by Blumenstock from ASDO. A consistent finding of these reports, including the one that we've been working so hard on, are echoed by national public health advocacy groups. It's the need for sustained investment in preparedness to address the boom and bust cycle of budget increases during emergencies and decreasing investments post hoc, and the need for investments to support public health infrastructure and capabilities to address both everyday and emergency events.
Paul, that's a great way to wrap us up. Thank you so much. So I just want to close things out here because I see we're at time. First of all, the goal for today was to incite a conversation, and clearly that has happened. I want to first thank all of you who work in public health. It's been my pleasure to get to know many of you on this project, but other work that we've done. And please know that while you may feel invisible, that there is many of us who honor you and admire you and respect the work that you do. Thank you to the Robert Wood Johnson Foundation. Clearly this work would not have happened without your support. Thank you to my colleagues, John Cattuso, Karen Lowrie, Ashley Koning, and Matt Drews, who worked so hard on this project. And thank you so much to our amazing project working group that kept us moving along and really raised critical issues. So in follow-up, everyone who's participated in the webinar will be hearing from us on a couple things. First of all, when the Bipartisan Policy Center report is available, we will email you and we'll post it on our website and show you where you can find it. When the Eagleton report in about a week is done, same thing, we'll let you know where to find it. Our full report, which will include the Eagleton report, should be done in about 2 weeks, maybe a couple days longer than that. Same thing, we will email you and let you know where to find it. We'll send you links to the recording of today, to the chat of today, to make sure you know how to find the project website. Please go there and look at the videos that are posted. They tell great stories. And we will be sending you an email with a link to the questions from the Eagleton survey, because we want to hear from you in terms of your perspectives with regards to the kinds of questions that we asked other New Jerseyans. So anyone else from the Rutgers team have anything else to add in? Anyone from the project working group?
Thank you, Jeanne.
Thank all of you. I think
John,
Thanks.
you guys did an amazing job putting everything together and coordinating.
Thank you.
We couldn't ask for a better crew, so thank you.
Well, hopefully this leaves all of you empowered to take some next steps forward, and we hope that these data and stories are helpful. So with that, I wish everyone good health, good public health, and thank you very much for joining us today. We'll follow up with you all by email. Take care.